So, you could see the topic name was given as laterality and asymmetry in clinical significance in neurology. With respected chairpersons, I would like to begin my talk. So, what is your idea? What was the topic? So, because in neurology, we would always want to know. So, asymmetry and laterality, significance in clinical neurology. So, I was thinking what I should speak, whether should speak on approach or anything. So, what I thought was, so normally we have symmetry in our body, like, but nature has given us one liver, one heart, we have two lungs, and intestine, even though single, they have a different functions. So, and we have brain, two hemispheres, and below that brain stem, spinal cord, and we have peripheral nervous system, muscles, all are more of symmetric. So, above that, especially above the thalamus, so there is some asymmetry. There is asymmetry across all the nervous system. So, I have chosen to speak on asymmetry in lateralization, means in some of the functions we will go through it. So, that will be basic thing for all of us to understand.
By given the deficit. So that is the main thing. Basically, they say author's razor is that can you explain with one lesion all the problem. So that is what this too requires sound knowledge of anatomy and the functions, neurophysiological functions. And the third and fourth part is what is the disease, how the disease is happening. Like is it a inflammation or it is a neoplastic, is it a vascular, it is an infection or it is a toxic metabolic, like that. So, and the last is what is the etiology. So that is what we want to know is pathology and etiology. That can come in only in the history. So, but otherwise, so these first two things requires a detailed history and the examination. So if you see a hemiplegia patient, so you examine, they will have hemiplegia. But it could be due to a tumor, it could be any of those things. But if you don't ask how it started, how it progressed, you will not arrive. So in this background, so we will discuss today's topic. So what is the general principle? So with few exceptions, nervous system is symmetric across the mid-sagittal. This is from a structural standpoint. It is symmetrical from the structural standpoint, but it is not functional one. So each part of the brain has got different function. And lateralization is like some functions are lateralized to one side. So this is last statement is like our Nityananda statement. So in neuroanatomical term, there is extensive lateralization among symmetric and asymmetric functions, and these lateralization are complex. What do you mean by that is extensive lateralization. Certain parts, language is in one hemisphere, visuospatial is in one hemisphere, and these are functions are asymmetric. So why this has happened is nature has allowed. See, motor system, only sensory motor, oculomotor system, this has got symmetry. So other things are not symmetrical because for the development. That's how we have developed. So one hemisphere has developed more into the language, another hemisphere has developed more into the. If you had equal representation, that means the evolution would not have happened. You would have been like a invertebrate animals and similarly, you can see this, but some asymmetry will be there. This is normal. So anatomically, you can see many of the ventricles. When you see the images, you can have asymmetry in the horns. Especially many times occipital horn may not be seen in many patients. That is not abnormal. So this is one of the important asymmetry we can see. You should not conclude that if some patient has come, until unless you see some other problems, this may be a normal phenomenon. So looking at the surface of the brain, surface structure is also reveals asymmetry. One of the major symptom asymmetry is the planum temporale, which is on the left side, which is longer on the left side. This is evolution. Even it can be seen in the fetus. So this is the main function which locates for a dominance for the left and right. This is the language area. Then it is the largest in the right in only 11%, whereas it is almost in 65 to 70%. It is largest in the left hemisphere, which makes us to have a dominance of this. So cerebral dominance may have structural correlate, including a longer planum terminale in the left hemisphere than in the right. So that makes us more left oriented. That's for the language. This symmetry can be seen in newborn infants, that these anatomies are genetically programmed. It's not that it's an acquired later. So genetically programmed, we can see even in the neonate, and have also been reaffirmed by the CT MRI. The relationship of such asymmetry language holds true in groups, but it is not sufficiently definite to predict it in an individual patient. If you see a big left hemisphere, it doesn't mean that they should be left dominant. So you should further evaluate this patient. So there are three main forms of brain asymmetry can be seen. One is based on the left and structural functional differences in the subcortical region, that is left and right difference in functional level, in the macrostructural level, and also in the connections. So you can see three types of asymmetries. This is evolution which has made us to become a better individual, better visuospatial organization at all. And these are all not by hook or crook. There is a genetic basis for it, there is an epigenetic basis. All these things are planned beforehand. So how do you evaluate for the knowing asymmetry, which is language? So lateralization of the language is very important. That's why in the history of neurology we ask, is a right-handed person or a left-handed person? So to know which hemisphere is dominant. So there is a because the hemispheric dominance is basically given for the language and the manual praxis, like what we learn movement, what I'm talking now, or we do the movements. So the main methods used are for this one is you can use what you call as Edinburgh handedness score. So based on there are certain scoring, how do you kick a ball, how do you throw a ball, all those things. So you can know the lateralization, which this is lateralized, and then this is another test, pegboard test, where there will be coins kept here, hooked to the left hand, right hand in 30 seconds. How much the hook can put peg. You can make, and you can classify this individual based on this as left-handed person or a right-handed person or a mixed. Mixed has not got much importance. We have to classify them as a left or a right. So coming to the lateralization, what is the main right hemisphere serves mainly non-language functions. So we should know this for postgraduates. Functions include visuospatial and constructional tasks. So, and knowledge of maps and topography, or which on the right hemisphere, dressing. So emotional feeling and processing. This is one of the main factors of the right side, right hemisphere. Left hemisphere we can speak, but the emotional aspect, interpretation is done by the emotional on the right side. Production of emotional intonation of speech and music appreciation. So this is the main function of the right hemisphere. So left hemisphere will produce the music, the tone, how you express, and all is by the right hemisphere. So left hemisphere main functions are language and then manual praxis. So these are the main functions of the left hemisphere. And we will come to know the problem whenever there is a injury to a part of the brain. So it has been understood. So the inferior parietal lobe is tied to the language function, especially reading and naming, calculation and arithmetic, and distinguishing from left and right. So the region is second part of the heteromodal. So heteromodal association area, especially in the frontal and the parietal, are the most advanced in the human beings. That makes us what we are. So along with the dorsolateral frontal cortex, the parietal association may be thought of center association of information of all sensory modalities, auditory, visual, sensory, which we pursue. So the lesion of this which causes what? So if you have a lesion here or a stroke or something is sitting, what it can cause? Okay. So the Gerstmann syndrome. So the patient, so this is the function of the, so this is the lateralization. So this, if it happens on the right side, you will not get Gerstmann syndrome. You will see that. This is what you mean asymmetry and lateralization. So inferior parietal lobe on the right is involved with body schema. Means we can know which is left, which is right, if you the left side of the people. So the lesion to this will cause what you call as anosognosia. So patient will not be aware of the left half of the body. So if you draw a line, he will not be able to see the left side. He will say he does not have any issue. So the schema, body schema is into the right inferior. So however, but superior parietal has got, as I told you, the lateralization symmetry. We have higher order sensory like stereognosis, then 2-point discrimination, all this will be there. These are more symmetric function. Right will control the left, left hemisphere will control the right. So this is what the first statement. Some lateralization of the symmetry will be there and asymmetry also will be there. Coming to the right parietal lobe, so as we already discussed, so this is more causes like Gerstmann syndrome. The patient is unable to calculate. In the right parietal lobe, they will be having neurobehavioral deficit. It's not Gerstmann's. Right parietal will have important neurobehavioral deficit, including neglect of the left side of the body and dressing apraxia. Somebody is not able to dress, it is not on the left hemisphere, it is more onto the rest. And then other spatial topographical dysfunction associated with right, they are difficult to find one way around and inability to draw or read a map. Geographical memory is more onto the right hemisphere. The retrospinal part of the occipital lobe also helps in topographic. And the last thing is constructional task, drawing, map, all copying the figure. All these are function of the right hemisphere, right parietal lobe. So what is the function of the right hemisphere in the language? So left hemisphere is the dominant in the language, but right hemisphere also contributes basically to pragmatism. So I can say get out. Okay, so if I say in a very angry get out, the students may not understand. So that requires right hemisphere. So to understand the intonation, that is what is my pragmatism. What we are expressing, how we are talking, and the people who understand. Whereas grammatics and semantics is on to the left. The meaning, grammar, thought in the left. So right hemisphere language is basically understanding the communication, how we speak, and the people understanding. So that's one of the important functions. So in a patient with right hemispheric, especially right hemispheric problem, so they will have a lot of social issues. So they will not understand the sarcasm, they will not understand the critics, they just understand the literal meaning. That is what happens in the right hemispheric lesion. Lateralized, especially the superior temporal gyrus, is one of the structures for language, basically the wordings, and it has been shown that there is something called as BTLA, basal temporal language area, in the inferior temporal lobe also, inferior temporal gyrus, because it was seen some surgical resection had caused language deficit, but they recovered. But predominantly the language is in the left superior temporal gyrus. So right temporal lobe, in non-eloquent areas, it will be usually silent. The patient may not have any other cognitive problem, but in an acute lesion, they can have confusion, delusions, thinking or delirium. So especially the rhythm and musical qualities will be affected if there is a right temporal lesion. So music they may not be able to understand, they may not be able to understand the raga, tala, all those things, they may not be able to do that. So bilateral temporal lesions, as I told you, memory, like you have the Pepper circuit on both sides, but they have little different function. So both bilateral, they will have problem in both verbal and non-verbal memory, but however, if you have a lesion of only the left temporal, you will have problem in the verbal memory, whereas if you have a lesion on the right temporal, you will have a problem with the non-verbal memory. So this is what we call lateralization. Even though the symmetry is there in the memory production, but the lateralization from the verbal is in the left hemisphere, left temporal, whereas non-verbal memory will be in the right temporal. Similarly, frontal lobe also has got variation, left and right. Language, you know, all of you know, left is Broca's area, and it is a cognitive selection which is driven by the content of working memory. So that is the function of the left frontal lobe. Context dependent behavior. So based on I have to come here, I have to talk. So how I should talk. So all these things are on the left frontal, rational and logical thinking. So if you have a damage to the left hand frontal, the logical thinking will go. Quantitative thinking, which is thinking that has to do with numbers and statistics. So if you have frontal lobe dysfunction, you will not be able to do. Analytical reasoning, which is the ability to make decision after considering facts. So these are all functions of the left frontal lobe. So why this is important is when you take a history, when you are examining a patient, so this will give you an idea. You can localize to which lateral, these functions are lateralized to one side. So however, right frontal lobe, non-verbal abilities and cognitive selection driven by external environment, and it also play a role in emotion associated with avoidance, fear and anger and disgust. So right is more of fear, anger, disgust, whereas left is more content oriented, you do based on what is the situation. And frontal lobe asymmetry has been seen. So frontal asymmetry can reflect activation of brain system involved in emotions such as fear, anger and approach behavior. Depression, if there is a lesion to the lower left frontal activity, anxiety in the right frontal, and fear greater in the right frontal. So anxiety, fear will be more in the right frontal problem, whereas more of emotional thing will be in the left. So laterality, so this is based on the functionality. So there are evidence that all we know neurodegenerative diseases are equal symmetrical onset, but many of the neurodegenerative, the common neurodegenerative like Parkinson's, what we see in day-to-day practice, ALS, Alzheimer's disease, they all have some laterality. So it is not starts symmetrical, it starts as asymmetric. So this brain asymmetry and a lot of research is going on. I also didn't know, so many papers are there on the laterality based on your handedness. I will not go to detail of it, I will just explain few of these things. All of us know Parkinson's is unilateral onset. It starts either on the right or left, starts with tremors, rigidity, and unilateral onset asymmetry is often seen. But in the imaging, if you see, you may not be able to see in the structural imaging, but if you do the PET and all, you can see the difference between the right vessel ganglia and the left vessel ganglia. What one should know that is motor symptoms, if it is started on the right side first, then if you do cognitive assessment, they will have some problem in the language. And if the patient has got problem, if it started in the left side, so they will have problem in mode of non-verbal task memory. So this you can clinically see, examine these patients. And in PD, patients with predominant left-sided motor symptoms are more likely to show impairment of the task involving spatial attention, left dominant, and these are the other things. We should observe this. I thought I will observe all my patients in future. Left dominant motor symptoms frequently have anxiety and depression. So whereas right, this one they can have behavioral disorder. So similarly in a normal aging, what really happens is, so lateralized, so right hemisphere, some part of, especially the insula and temporal cortex atrophy. On the left side, it is lateral temporal cortical, which will happen in the normal aging. But in Alzheimer's disease, this happens in a faster. So in the Alzheimer's disease, it's the first thing to start on the left anterior temporal atrophy. So this is what we can know this, and this interhemispheric differences have been seen in many of the studies. Similarly, in ALS also you can see the onset in asymmetry when it usually starts in the upper limb. Usually the dominant side, it starts on the right side. But since we are using simultaneously both the legs, so you don't see that asymmetry. So in ALS, you can see the laterality occurring more on the right side. So this asymmetry in neurodegeneration is a relative biomarker. Sometimes this is when somebody comes in a PD patient, if you have an asymmetric onset, progressive, tremor dominant, you always think it is an IPD rather than thinking it is something like a Parkinson's plus. So that's one of the clues. Similarly in ALS, it started unilaterally, slowly progressive to the other. That is also one of the markers to say it is ALS. And it has been shown, meta-analysis showed pronounced atrophy are evident in left putamen in Huntington's disease. So reason we don't know, but what has been observed is putamen is more in Huntington's disease, right hippocampus in patients with mild cognitive impairment. So MCI patients will have right hippocampus, whereas in Alzheimer's disease patient, they will have more of the left hippocampus. So, but no consistent pattern has found in Parkinson's disease. So as I mentioned, functionally it may be different, but structurally you don't see any problem. So there are so many papers. So what has been found that left-handed individuals experience various neuropsychological conditions including depression, anxiety, alcohol addiction and schizophrenia. I think we should look into that. So handedness is also been implicated. So handedness does not come just by nature, it's by not by random. It has a lot of endogenous proteins problem, genetics, all these things will define us. And if you can see, there are diagrams here so showing asymmetric onset of the disease. So why it becomes asymmetric? There are a lot of theories. In Parkinson's they say vagus. So usually all we know that Parkinson's starts in the gut, the synucleinopathy, and migrates to the brain. So the longer the vagus, which side it reaches first. So these are all theories that we may have to observe in future. So disease implication. Asymmetries can influence the presentation and severity, which I have told earlier. So all of us sometimes may have a right vertebral artery hypoplasia, left transverse sinus hypoplasia. Suppose if the dominant gets affected, then the patient will have extensive infarction. So one should always be aware that asymmetry in the normality. Basically, hypoplastic vessels, when the occlusion happens in the larger, in the dominant, they will have a problem. So this is basically the asymmetry and lateralization for the brain functions. The rest of all the functions in the spinal cord and in the muscle, in the brachial plexus and all are symmetric. So based on certain things, clinically, we may localize or diagnose a disease. I am not going in detail. Few of the things. Some patients come with sensory symptoms in both the lower limbs. So you always suspect it's a polyneuropathy. But by definition, polyneuropathy is symmetrical onset. Somebody has come to you with bilateral, but later if you are getting in the history, it is an asymmetric onset. So it is very, very unlikely to be a polyneuropathy. Usually you diagnose this to be having a mononeuropathy multiplex. So similarly in the history, it is very, very important, the onset, progression, symmetric, and many times we say symmetric onset is usually metabolic and toxins. So some of the metabolic disorders are not symmetric. So examples is, so hyperglycemia induced, you could have seen chorea, hemichorea, hemipalesmus, it affects one side rather than the bilateral. So there are exceptions in neurology for everything. Symmetric onset does not mean it is always a degenerative. Okay, it can be or a metabolic. Sometimes symmetry can be seen in an acquired disorder also. So other way around also is true. So this is what I was going to talk to you. So in conclusion, what we can say, brain asymmetry, that is structural and functional difference between the left and right hemispheres, are major source of inter-individuals. Each human being is different. Each of us are different. Even in twins it is different. So it depends on it. And neurologists must be aware of normal asymmetries to differentiate from pathological conditions, especially diagnostic, imaging and clinical assessment. So this is very important as to know is what is normal, when you can give it off, which is abnormal. Induced variability in brain asymmetry needs to be considered in the assessment of symptoms and treatment of various disorders. And altered brain waves are observed in several neurological, neuropsychiatric and neurodegenerative disorders. So these are all the references I think you can go through. So which has been described all these things. This is as latest as in Natures of Neurology. So there is an article on clinical implication of brain asymmetry. They describe all the genetic basis for all the asymmetries. Thank you.
Comments. One for PGs. Sir has nicely explained that all parts, all components of the language are on the left hemisphere except one component. What do you call that as? Intonation. Yeah, prosody. Very good. Prosody. So second comment I want to make is that regarding lateralization or asymmetry, one very good disorder has been described. That is alexia without agraphia. So whenever we see on the right side, it goes into the left side. So language area is easy to access. So whatever I see on the right side, to convert it into language form is easy. But whatever I see on the left side, it takes longer time because it goes to my right occipital cortex. It has to cross the corpus callosum and then access the language area. So it takes a longer time. So a person with left PCA infarct will have alexia without agraphia. He can write, but he cannot read what he has written because from right cortex it has to go to the language, it takes time, and if there's a lesion in the spleen of the corpus callosum, it cannot. But right PCA infarct, there's no problem. Left side it goes to the occipital cortex, it can immediately convert it to language. So one important disorder regarding to asymmetry is alexia without agraphia, which is seen only when the left PCA cortex is affected. Any comments or any
other thing is
suggestions?
a lot of experiments have been in split brain personality. So when the corpus callosum is cut in epilepsy and you give two images like cat and dog, you can clearly differentiate. They will not know what is there on the right side. Visuospatial function is of the right hemisphere. Whatever that is kept on the left side, the patient is not able to aware. On the right side, they will be able to tell. So like this, they have defined all the functions. As I was telling, there are a lot of lateralization. So sound knowledge of anatomy helps us in, when a patient comes with a given problem, analyze it and always try to localize. Say right now what is happening in neurology is you go see first scan and then try to come and see the patient. So rather than we should examine, make a clinical conclusion and then see the imaging. So the reverse is happening now. Students see the MRI and actually if MRI is normal then the real neurology starts. So then they'll start go examine the patient. Otherwise it is happening. So all of us should make, before opening an imaging, at least write it down what is your problem, and so that will help you in lateralization and then knowing the symmetry or asymmetry.
Can I just make one more comment? The explanation for the spatial localization to the right parietal lobe is that the right parietal lobe controls both the right and the left extrapersonal space, whereas left parietal lobe controls only the right extrapersonal space. So the left parietal lobe is affected, the right extrapersonal space is gone, but it is compensated by the intact right parietal lobe which controls both the right and the left. And therefore the left parietal lobe usually you do not see any heminephrid. Whereas if right parietal lobe gets affected, both the right and the left extrapersonal space is gone. The right extrapersonal space is compensated by the intact left parietal lobe, but there is no compensation on the left side. So hemi neglect or spatial disorganization is seen only with right parietal lobe lesions and not usually with left parietal lobe lesions. Thank you, sir.
Next presentation, I request Dr. Ramakrishna sir and Dr. Rudresh sir to chair the session. I invite Dr. Ashish Apte sir to present on letting the brain imaging concepts.
కెమెరాలు పెట్టేస్తే వదిలేసి మాట్లాడుకుందాం మనం.
I am missing something, or what is responsible for patient's current symptoms is not what I am seeing on imaging. Blood looks very similar in various stages. When it goes from hyperacute to acute to subacute, it is just matter of 3 or 7 days. And the ICTUS has to perfectly correlate as to what we are seeing on imaging Otherwise, we are going to make a mistake in kind of labeling that patient's ictus is indeed related to what we are seeing on imaging. So that is why we have to determine what is the age of hemorrhage that we are seeing on imaging, and we obviously are going to try and aid our clinician friends in managing this hemorrhage and in prognostication. Now, how do we recognize presence of bleed in brain? Now, on CT scan, all of you clinicians, all students, in fact MBBS students, are able to say whether this is bleed or not in one go. You don't need any knowledge of radiology at all, because blood looks very, very dense, and rest of all pathologies do not look dense. So it is very straightforward, simple thing to identify hemorrhage on CT scan. So I am not going to talk much on CT scan because it is very straightforward. On MR, however, the problem is challenging. And why that is challenging is because the MR appearances of hemorrhage change as to how old is the bleed. That is the first thing. Bleed which has happened 30 minutes back looks vastly different from what it will look when it has happened 7 days ago. And this appearance changes and depends upon what kind of hemoglobin is present in that blood clot, whether it is oxyhemoglobin, deoxyhemoglobin, or whether it is methemoglobin, whether the clot has intact RBCs or the RBC walls have been destroyed, as will happen with subacute and chronic hemorrhages. On what sequence are we on MR sequence are we looking at this hemorrhage? Are we looking at hemorrhage on T1 and trying to judge what is the age? Are we looking on a gradient echo, or are we looking on a susceptible equated? Or the favorite one of all of us, are we looking at diffusion and trying to identify the age of the hemorrhage? And there are certain other factors which are like what is the partial pressure of oxygen in the tissue where the bleeding has happened, what is the local pH, and what is the patient's hematocrit. For example, a very, very anemic patient, a patient with, say, leukemia, who has very low hemoglobin, his intracranial hemorrhage will look slightly different from a patient who is polycythemic or has the normal hemoglobin. That is because it is related to the hematocrit and number of RBC density in that area of hemorrhage. The same principle of density will follow on CT scan as well, because CT hemorrhage density is also dependent on hematocrit. But as against CT, it is not only the hematocrit and the density of the blood which is kind of determining MR appearances, but there are several of these other factors which are important for us to know before we analyze this bleeding. Now we have to understand why such a thing happens on MR. It is not so simple, right? Why should appearances change in hours and days on MR of the same sequence? Now we will try to understand this by knowing a little bit of physics. I know all of you are clinicians, but if you don't know these basic things, they are really basic things. I am not going to teach physics per se, but what I am going to tell you is that there are various types of substances in the human body. Those are called, say, ferromagnetic, which we are really scared of, like amusement clips, etc. And we don't want to deal with them. In fact, we want, if they are present, like sharpnels or bullets, we don't want to image these patients at all, because these are the substances which get magnetized by external magnetic field and they get displaced. So these substances which have a lot of unpaired electrons in their molecule are called ferromagnetic substances, and those are our enemies. We don't want to deal with. But there are certain other substances which are not so magnetic, and those are called by various names like diamagnetic, paramagnetic, superparamagnetic, etc. So our body is largely made up of diamagnetic substances. What it means is that these substances have very few unpaired electrons in their orbits. And if you have less unpaired electrons, then these substances cause very less changes in the internal magnetic field when they are exposed to, say, MRI magnetic field. So largely, they will not distort the magnetic field. And most of the human body tissues are diamagnetic. There are hardly any free electrons in their outer orbits. Now, as far as hemorrhage goes, there is one component of hemorrhage where the blood acts like a diamagnetic substance, and that is in the oxyhemoglobin stage. What it means is that at this stage, on MR imaging, bleeding is going to be very difficult to detect because it is not going to cause much field changes when subjected to external magnetic field. Are you with me? Great. Now let's look at the other kind of substances. substances, which are called paramagnetic substances. They are slightly more magnetizable. That means they have more unpaired electrons in their orbits as compared to diamagnetic substances. And that's why they are likely to cause changes which are visible to us when subjected to external magnetic field like MRI imaging and MRI imaging. Now we have to know which kind of blood in what stage acts as a paramagnetic substance, and that is deoxyhemoglobin. Now this stage is very important for us is because conversion to oxy to deoxyhemoglobin starts very early and it lasts for about 7 days. So blood is in deoxyhemoglobin stage for a long period of time when patient is actually come to us for imaging and evaluation, right? And hyperacute bleed is kind of very rare to see on MR. Most of the time by patients when they reach the hospitals and they are imaged, they are about 1 to 3 days old and the blood is already converted into deoxyhemoglobin stage, and that is a paramagnetic substance, right? Now there is another substance as regards the hemorrhage which is called superparamagnetic. Here the molecules tend to have higher number of unpaired electrons as compared to paramagnetic, but lesser as compared to ferromagnetic. So in case of blood, it is the methemoglobin which is responsible for the signal changes at this stage. And as you know, if you see methemoglobin on say susceptibility weighted MR images, it causes very dark signal and is very easy to identify. That is because the susceptibility changes or the magnetic field changes that methemoglobin causes are very striking. And why they are striking is because it is a superparamagnetic substance. Okay? We saw what ferromagnetism means, and as I said, we really don't want to deal with these objects. If these objects are actually present in patient's body, we don't want to do MR for such patients. Now, I have been talking about these unpaired electrons in the orbit all the time, right? Why there is so much fuss about this unpaired electron? Now, what these unpaired electrons do is, this is a very technical physical term, but good to impress your examiners if they ask you that they are responsible for what is called as proton-electron dipole interaction, PEDD. Now, proton-electron dipole interaction, what it means actually is that these free electrons, if there are more number of free electrons as happened in ferrous state, then this proton-proton dipole interaction is very high. If this interaction is very high, that means these substances are likely to cause more changes in the local magnetic field when they are subjected to external magnetic field. That is beneficial for us because we can detect these changes easily on say T1, T2 gradient echo images, and that's why we can identify the blood degradation products more easily, or they are more apparent to us. Okay. Now everyone talks about this susceptibility effect, right? Everyone, as soon as anybody asks you, is there hemorrhage in blood? A radiology resident or radiology clinician will tell you, yeah, there are marked susceptibility changes, so it is likely to be blood. Okay, this is what the standard answer radiologists give. What are they meaning by these susceptibility changes? What we mean by these susceptibility changes is again the same thing. Whenever these iron molecules are going to have this higher number of free electrons in their outer orbits, they are going to be more and more magnetizable. If they are more and more magnetizable by external magnetic field, they are going to cause more and more inhomogeneity in the local magnetic field. If they are causing inhomogeneity in local magnetic field, we are able to detect them. And if we use a special sequence, which we call as gradient echo, all of you are aware of it, gradient echo or susceptibility weighted MR imaging sequence, then this effect of change in the local magnetic field is going to be more and more apparent, and it is going to be best seen on SWI images, which is going to make this area very dark, and that's why we are going to identify as an area of excellent contrast against the bright CSF or bright brain tissue. Okay, that is what we mean by susceptibility effect. Now on MR, the signal intensity of this hemorrhage depends on various factors, and we have seen that one is, to revise this, is the actual chemical state of heme, that is whether it is in oxyhemoglobin or deoxyhemoglobin or it is in the hemocytic stage, and also whether this heme molecule which is present in this plot is contained within the intact RBC membrane, or the RBC membrane or their wall is lysed and this heme molecule has come out and has admixed with the adjoining plasma and the surrounding edematous brain tissue. So these two factors really determine how the blood is going to look on MR. Now in case of hemorrhage, as we have already seen, blood behaves as a diamagnetic substance in oxyhemoglobin stage. It becomes as a paramagnetic substance in deoxy and methemoglobin stage, and it behaves like a super paramagnetic substance in hemocytic stage. So if I were to ask you which of these are going to cause most apparent susceptibility changes on imaging, what could be grading order, which is going to be the most apparent or cause most prominent susceptibility changes, whether it is going to be oxyhemoglobin or whether it is going to be hemocytic. Middleman will always remain middleman, right? Okay, so super paramagnetic, you have got me right. So if you have understood this, then the rest of the talk is really immaterial to you, because I am just going to show you example of hemorrhage in various stages and how to identify them. If you have got this right, that this is going to be the most susceptible man and this is going to be the least susceptible man, the middle man will remain middle. Let's look at some examples. Now this is blood in hyperacute stage. That means patient is presented in first couple of hours and he has had an acute neurological deficit, left-sided weakness, and this is the MR that we are going to see. Now at this stage we know that blood is in oxyhemoglobin stage. It is still, the oxygenation of heme molecule is still maintained. The RBCs are still intact, they are not lysed. So the blood is actually in what stage? Diamagnetic stage. What I told you, that on diamagnetic stage you are not going to be able to differentiate blood from the other brain tissues, because it is not causing any changes in the local magnetic field, right? So that is what happens on T1. We hardly see area of hemorrhage. It looks almost like normal brain tissue. It should look similar on T2, because I have told you that it doesn't cause any change in the magnetic field. But that does not happen. Why that does not happen is not because of presence of blood or blood degradation products, but along with the RBCs and the heme molecules, there is obvious exudation of plasma, right? Plasma is a proteinaceous water. How does water look on T2 weighted images? How do ventricles look on T2 weighted images? They look bright. So the water which has exuded out of the blood vessel, along with of course RBCs, is going to look bright. So it is nothing related to actually the blood product as such or heme product as such that the bleeding appears hyper intense on T2 weighted images, but it is essentially because of the water content of this blood clot that makes it look bright on T2 weighted images. Very clear? Diamagnetic substance, we don't expect much changes. Changes are essentially because of the water which has come out along with the RBCs. Let's move to the next stage. And this is the stage where we commonly get the patients for imaging, or this is the stage where we commonly see blood. Now it is an acute phase. What happens after deoxyhemoglobin converts its oxygen, it is deprived of oxygen, it is going to get converted into deoxyhemoglobin. But the RBC wall is not lysed immediately. So the RBC wall is intact and the heme molecule has just got converted from oxyhemoglobin to deoxyhemoglobin. Right? Now, deoxyhemoglobin, what kind of a substance it is? It is paramagnetic. It is a middleman. It is going to cause some changes, but not very apparent changes. Right? So, some changes are more apparent on T2 weighted images than on T1 weighted images. Which imaging, if I ask you which imaging sequence you like the most, you would say flare, right? Or T2. Because all pathologies are more apparent on that sequence. So remember that because the pathological changes are more apparent on these T2 weighted images, the changes of susceptibility of deoxyhemoglobin also are more apparent on this imaging sequence. That's why the blood at this stage on T2 weighted images starts looking dark, because it is now a paramagnetic substance. We know it causes inhomogeneity in the local field and causes susceptibility, so we know that it will look dark. While on T1 weighted images, there are not much changes there. There are subtle changes, but what we are looking essentially at T2 weighted image, and the blood is looking dark at this stage, which is the acute phase. Let's move on to the subacute phase, which is between 3rd day of hemorrhage to 7th day of hemorrhage. What has happened here is that the RBC walls are still intact, but now deoxyhemoglobin has converted into methemoglobin. Now methemoglobin is a superparamagnetic substance. What we see on these imaging is that on T1 weighted images, the blood starts becoming white. On earlier stage, it was hardly visible or was little hypo-intense or iso-intense as we call it, and it was dark on T2. Now what has happened? It has changed to becoming bright on T1 and is continuing to remain dark on T2. Very clear? The change has happened actually only on T1 weighted images. On T2, between acute and subacute, the blood is still looking dark. So that's why only on T2 weighted images, if I were to ask you to tell whether this is an acute or subacute bleed, will you be able to tell me? No, you can't. So there is no one picture that tells you the entire story. You have to look at all profile pictures of a person to kind of understand how this person could be. So similarly, looking at just T2 and flare, which are our favorite sequences to look at, if you try to age hemorrhage, you will go wrong because you will not be able to differentiate acute from subacute. Very clear? So in this case, T1 weighted images help you because now the blood has started looking bright on T1 and is dark on T2. In late subacute stage, that is after 7 days to about a month after the hemorrhage, what happens is that now RBCs have their walls are destroyed, like it will happen with any other cell which is dead. So RBC walls are destroyed. The blood that was heme molecules which were there in the RBC, now they have come out of the RBC and they are now freely mixing with the surrounding CSF and the plasma and the surrounding necrotic tissue, and there is now whatever was contained in the RBC is no longer contained. Now, important thing to remember is that whenever the heme molecules are contained within something, the changes that we see on MR are more apparent or more obvious. Whenever they are out, the RBC walls are destroyed and heme molecules are diffusing everywhere, the susceptibility effect or the T2 darkening effect or the gradient darkening effect or the darkening effect on SWI, it all means the same, right? That effect is reduced. Okay, that's why now though the blood is continuing to look bright on T1, it has started looking bright on T2 as well, because that contentness of that heme is gone. So the susceptibility that it will cause will reduce. There is so much of plasma and the whole thing around there is necrotic. So there is more fluid, and fluid, as we know, looks bright on T2 and flare images. Right? Perfect. Now in chronic stage, obviously the blood clot further shrinks, the macrophages eat away the blood products, and then it is converted into hemosiderin. Hemosiderin is a superparamagnetic substance, as we know, and that's why blood is now seen as an area like this, which is shows very dark signal on the gradient or T2 or SWI images, and it is hardly seen on T1 and T2 weighted images, or on T2 weighted images you will see it as an area of hyperintensity merely because now it has got converted into a gliotic cavity which is fluid filled. So here again the signal is related to the presence of fluid or plasma or CSF, whatever you want to call it, and these signal changes are because of the presence of blood which is now within the cells, because it has been eaten away by macrophages. So again it is gone in the cells, and that causes more susceptibility. So contained blood is more susceptible as compared to uncontained blood. Very clear? Perfect. So this is what this table just summarizes what we have learned till now. For you to recollect it once again as to how the blood changes its appearances as the days go by. So initially it is nearly iso-intense, that means we hardly see on T1, and it is bright on T2. or flare, then it becomes iso and it is hypointense, then it turns bright and dark, then bright and bright, and then again it turns finally in chronic stages it is dark on all sequences. Perfect. This just puts those all slides together to make you have one more look at what we have seen in last 10 odd minutes, 10-15 minutes. Perfect. But if I were to ask you which is the most important sequence to detect hemorrhage in a given patient, what would your answer be? If I were to ask you to choose one sequence which will tell you कि hemorrhage है या नहीं है, and I am allowed to choose only one sequence, what will you look at? Right. So you will look at gradient or SWI images, and we know why we look at them is because what we are doing right now, looking at T1, T2, flare, whatever sequences, we are trying to assess how susceptible the blood clot is, right? And all the sequence changes are happening because of the susceptibility or the magnetic field inhomogeneity that this blood clot is causing. Now these changes are brought out best by one sequence which is called T2 star gradient echo, or its elder brother or sister or bigger brother or sister or father, that is SWI. Right? So SWI sequence is nothing but a better gradient echo or T2 star sequence. Why it is so is what we will see in subsequent talk. But for you at this moment, T2 star and SWI are one and the same. They bring out the dark signal that is caused by hemorrhage. And if you see the chronology, most of the times, after the first 24 hours, most of the times, blood is dark on T2. Right? So we are going to see this hemorrhage more commonly in T2 dark stage. That means SWI dark stage. That means T2 dark stage. And the T2 star or the gradient or the SWI brings out this darkness best to human eyes or to us. Right? That's why if we were to choose one sequence that we want to look at hemorrhage is SWI. But what it also tells you is that patient has come to you in first 30 minutes of acute onset stroke, SWI is unlikely to show you this hemorrhage as dark. Am I very clear? Because the susceptibility changes at this point are not occurring because blood is in oxyhemoglobin diamagnetic stage. So if you look at SWI for a patient who has come to you with stroke of 30 minutes and trying to decide whether I should thrombolize him or not, depending upon whether this is acute stroke of hemorrhage on MRI, you will go wrong. Is my point very clear? So at that point at least, don't look at SWI because it will not tell you anything. Very good. Now, just to bring this point more in light, we hardly see this area of hemorrhage on this T2 and T1 weighted images, but the SWI show it to us brilliantly, again because of the enhanced susceptibility. Now one more question to you. Does it mean that if you don't see dark signal on SWI, whatever pathology you are seeing is unlikely to be hemorrhage? You got my question? We saw that at SWI, on most of the occasion, blood looks dark. That's why we love SWI or T2 star sequences. So at any time or any pathology, if it is not dark on SWI or gradient, does that mean that I have excluded the diagnosis of hemorrhage? It is not blood and it is something else? It is very important for us, right? Clinically it is very important. Like for example here, now this is bright on flare, this is bright on T2, this is bright on T1. What is happening on SWI? It is bright, right? You can see the surrounding area of old hemorrhage as dark, so you cannot doubt me that this is not a SWI sequence at all. It is indeed a SWI sequence, but how is the hemorrhage appearing? It is appearing bright, right? So it is uncommon but not unusual to have hemorrhage looking bright on SWI. I will prove my point by showing you a CT that it is indeed hyperdense of 60 to 80 ounce per units and it is indeed hemorrhage. Okay? Physics, it is essentially because of presence of fluid, and we know how is the ventricle looking on this SWI. It is basically a T2 weighted sequence. So if the hemorrhage is containing more of fluid, more of plasma, it will look bright like on T2 weighted images, even on SWI. But what is actually happening, if you look carefully, is that there is a rim of this hypointensity around it, which will allow you to diagnose this correctly as hemorrhage. Fine. Now let's answer this question one. Dr. Sampath, you let me know whenever my time is getting close. I am just going on because they said, yeah, I have to. Okay. So let's answer this debate about who is better. Gradient echo imaging is better or SWI better. Now all of us are using SWI images routinely, right? Now SWI images have one good thing. They have one more set of images apart from what we used to get with T2 star or gradient echo image, which are called phase images. So on your left side of your screen here, these are the SWI images. Now you can see these micro hemorrhages which are looking dark on this SWI images. How are they looking on these phase images? The right hand side is the phase images, and how are they looking on these phase images? They are also looking dark, right? So the appearance of these two images is similar. On the SWI has two components. One is called as SWI magnitude images, and these are the phase images. So the hemorrhage looks similar on SWI magnitude and the phase images. As against that, look at here. Here also, these are SWI images. These are showing you this tiny area of hypo. Can you appreciate them? Hypointensity there. I will magnify it for you. Right? You see them there? They are dark. But now let's see what happens to them on phase images. So these are the phase images. What has happened to those areas on phase images? They are actually looking white. Right? So if you look at these two sets of images and you see on SWI something is dark, but on phase images it is looking, the same thing is looking white, then it is likely to be calcification and not hemorrhage. So SWI images, as against the conventional T2 star or gradient echo images, allow us one advantage, that they allow us differentiation of calcification from hemorrhage. Now we have to understand how blood looks on diffusion, because in acute settings, when patient is coming to you with an acute neurological deficit, you want to differentiate whether this is hemorrhage or in fact you decide on thrombolysis, right? That is our primary aim. Now hemorrhage is actually bright on diffusion weighted MR images only at two stages. One is in hyperacute stage when blood is in oxyhemoglobin stage, and at other stage when it is in extracellular methemoglobin stage, where it is late subacute. Only these two stages blood looks bright on diffusion. On all other times it looks dark. Let's see the example. Acute hemorrhage. Why we know? We are seeing hardly any signal change on T1. The blood looks bright on T2. How is it looking on diffusion? Diffusion is bright and it is dark on ADC. Now why this happens is because at this stage there is the blood clot is forming. So there is some fibrin network which is laid down, and there is alteration in RBC morph. RBC starts swelling before they lyse. So a swollen cell, less extracellular space, the lesion becomes diffusion restricted. So that's why in acute stage the blood is diffusion restricted. And it also appears bright in late subacute stage when blood is in extracellular methemoglobin stage, and that is essentially because of the T2 shine through effect. If you look here, the blood is bright on T1, it is bright on T2, it is bright on diffusion, but it is hardly dark on ADC maps. So this brightness on diffusion weighted MR images at this stage is essentially because this hemorrhage is very bright on T2. It is called T2 shine through effect, and it is not true diffusion restriction. What we have to know actually is what happens in the acute stage of hemorrhage, because that is where most of the patients are going to present to us. And that is where we should be clearly able to differentiate hemorrhage from infarct. Now look at this image. How is blood looking here? This is an area of signal alteration which is nearly iso to slightly hypointense on T1. It is looking very dark on T2. How is it looking on gradient? It is looking dark. How is it looking on diffusion? It is dark and dark. Right? Now, on diffusion, this darkness is essentially caused by an effect which is called T2 washout. Like this T2 shine through, that means very bright lesions on T2 appear diffusion bright, though they are not truly diffusion restricted. That is called T2 shine through. Like that, very dark lesions on T2 appear dark on diffusion, which is called T2 washout. So, a large blob of calcification, anything which is very dark on T2 will appear dark on diffusion, no matter what the rest of the contents are. So that is called T2 washout, and that is how blood looks on diffusion in acute stage. Now the question to you is, can one differentiate acute infarct from hyperacute bleed using diffusion-rated MR images? Right? All of you want, when patient comes with acute neurodeficit, you want to be sure whether it is hyperacute infarct or not, and whether it is in the window period or not, then you should thrombolate. Okay? And as we know, on most of the scanning centers or most of the departments, it is the MR which is now the preferred modality because of the easy availability, rapid techniques that we have developed. That patient is in and out within 5 or 7 minutes, and that's why CT is largely replaced by MR. Now, can one differentiate acute infarct from hyperacute bleed on these diffusion-rated MR images which we use to diagnose hyperacute infarct? And what is your answer? Can you differentiate? It's not possible. We need to take help of other MR imaging sequences, or we anyway have to go CT. If this is the answer, why do an MR? Right? This cannot be an answer. So what are the three things that you will choose? Correct. So the best thing whenever a question like this is asked in a conference is to ask the imageologist to show more, because that is what he wants to do. So it is always beneficial to look at other MR imaging sequences, and I will show an example of it. An 80-year-old man was presented with acute onset of left-sided weakness in last 30 minutes. This is what the diffusion imaging shows. We are seeing a focal area of diffusion restriction, bright on diffusion, dark on ADC, and is planned for thrombolysis. Will you thrombolize? Will you not? Everything is correct, right? What I have not done is probably perfusion to show you the phenomena, but we hardly do it. When you see this, you will thrombolize it, or you will not thrombolize this. What will you do? Since the prior question is a leading question to this, I will always say that I will look at the other imaging sequences. But 30 minutes on set, neurodeficit cannot look bright on flare images. Right? So a pathology which is looking bright on T2 and flare and is diffusion restricted cannot be acute infarct if it has happened within the last 30 minutes. We are trusting the onset of ictus. If you are not sure of that, then this question is not valid, because then we don't know at what stage we are looking at it. Okay? One more example. Hyperacute infarct, diffusion restricted, bright on diffusion, dark on ADC, you hardly see on T2. As against that, hemorrhage, diffusion restricted, you are already seeing it on flare and T2. So, in a hyperacute stage, if you are seeing a pathology which is diffusion restricted, but is also bright on flare and T2, that means it is not infarct, it is likely to be hemorrhage. Is my point very clear? Coming to CT, I think I said I will not spend much time. What we have to know is that there are certain important things that we can identify on CT, is that we can know the areas of recurrent bleed because they appear different in various stages of hyperdensity, and if we see this variegated appearance, we know that there is recurrent hemorrhage in it. We also can identify acute hemorrhage in already existent bleed like this, because it appears less dense as compared to the organized clot, which is going to appear more dense. So a fresh area of bleed can be identified as a less hyperdensity as compared to the old bleed, which is going to be more hyperdense. Coming to intracranial hemorrhage, this is something which I can stop whenever you want me to, because I'm just going to show you a few examples of this and how we localize the the bleed to intra or extraction compartment. This is pretty basic, but just a revision. Like, for example, this is a large area of hemorrhage within the right thalamus. We know that this is interaxial because it is surrounded from all sides by brain parenchyma, and that's why we know that it is interaxial. As against that, this bleed is surrounded from one side by the brain parenchyma, and that's why we know that it is not interaxial, but in the outside the brain compartment. For extraxial hemorrhage, how do we localize it to epidural or subdural compartment? Is by the shape of the inner surface of this bleed and what we call by pear and banana sign. If it is biconvex like this, then it is an extraction hemorrhage. Of course, you will have associated overlying fracture, etc. And if it is a concave inner margin like this, what we call as banana shape, then it is likely to be in the subdural compartment. Moving on to subarachnoid and intraventricular hemorrhage. Now, hemorrhage here behaves differently as compared to how blood behaves when it is within the brain parenchyma or in subdural or epidural space. And why that happens is because now the blood is admixed with CSF, which is predominantly fluid, and that's why the signal changes that this is caused by this area of bleed are going to largely be dependent on how much of this fluid is there and how much of the bleeding has happened. Okay, so subarachnoid hemorrhage in acute stage is very difficult to detect on T1 weighted images because the increase in the protein contents of the CSF that are caused by these small leaks, they are unlikely to cause any signal changes on T1 weighted images. So on T1 and T2 weighted images, subarachnoid hemorrhage is very easy. Acute subarachnoid hemorrhage is very easy to miss. On flare, this signal abnormality is apparent. So if you want to use MR imaging for evaluation of acute subarachnoid hemorrhage, you must use flare images, and you can combine it with the SWI image. So because even other inflammatory meningeal pathology is going to look similar on flare images as subarachnoid hemorrhage, and both are going to look bright. Here is an example, right? The subarachnoid hemorrhage is hardly apparent on T1 and T2 weighted images. We cannot see anything in that salient fissure, but on flare images, it appears as an area of hyperintensity because of the change in the composition of the CSF to which flare imaging is very sensitive. On SWI images, again, this may not be very apparent if the bleeding is very small, but it is apparent when the bleeding is chronic, or we are seeing it in pyelocidrosis stage like this, when there is chronic subarachnoid hemorrhage and the RBCs are now in the macrophages and are lining the subarachnoid space like this, and the SWI imaging is very sensitive in detecting these areas of pyelocidrosis. Moving on to the etiologies, we can primary intracranial hemorrhage is most common cause, of course, is hypertension, and we identify this by history of. I'm going to stop. So if you are ready with the 5 minutes, okay, you let me know when to stop. Then I'm just showing you a few examples. These are the classical areas of hemorrhage when the cause is hypertension. The commonest, of course, is the putamen, followed by thalami, then cerebellum, and then the brainstem. If that was in primary intracranial hemorrhage due to hypertension, what does this look like? This looks similar, but the site is slightly atypical, right? It is not one of the classical sites for hypertensive hemorrhage. If you see that, then you have to look beyond what is obvious. As in this case, you see this small area of abnormal flow void in that right salient fissure. If you analyze the contrast enhanced images which we had done here, you see an MC aneurysm which had caused intraparenchymal hemorrhage. So if the bleed is not in the typical site, and even though the patient is hypertension, then you have to look at what is beyond obvious. Now this is something which is related to hypertension. So what do we call it? Multiple white matter signal changes along with chronic areas of blood staining or blood degradation products or microhemorrhages, Binswanger's disease, right? If you see a hemispheric hemorrhage like this, which is not at typical hypertensive sites, and you see multiple areas of microhemorrhages, what is the likely etiology? It is going to be amyloid angiopathy. Now secondary hemorrhage like this can happen, and we can diagnose it on imaging by observing that there are multiple abnormal flow voids, as we call it, forming that angle of vessels, and we know that this is a vascular malformation. If we do an MR angiogram, we will pick up that this large anterior cerebral artery is supplying this vascular malformation, and there is premature venous opacification on this side, knowing that it is an AVM. There could be areas, there could be certain benign lesions like cavernous angiomas like this, which can have acute hemorrhage, and many times these cavernous angiomas are associated with developmental venous anomalies, which are best brought out on the SWI imaging or the post-contrast imaging. The typical appearance of these cavernous angiomas is that popcorn appearance on T1 weighted images, where you see multiple areas of T1 hyperintensity, and it is a complete T2 hypointense rim at the periphery, which is containing this T1 and T2 hyperintense area. Typical appearance of popcorn appearance of cavernous angioma. These lesions could also bleed, and that is one of the cause of secondary hemorrhage. Infarct can also bleed because of the increased vascularity, neovascularization that happens because of the reperfusion injury, and we know that this is an hemorrhage in an infarct because it conforms to an arterial territory, and that's how we would know that is infarct, that is hemorrhage in an infarct. Now this brings me to the last part of my talk, and that is quiz. Right? We have ended with a quiz. Now this patient, 35-year-old lady, has episodic throbbing headache. She has had multiple episodes in the past few weeks. There has been spontaneous resolution of these headaches. There is no history of any seizures or neurodeficit, and she has presented to casualty with one such episode of severe headache 1 hour back, and this is what her MR imaging is showing. So what are we seeing on these MR images? We see nothing on diffusion. We see some abnormality on flare and on gradient here. And this is her MR angiogram. Yeah, I'm done. So how do you put these things together? You see these multiple areas of vascular irregularity. A 35-year-old lady who has come with acute onset of headache, multiple episodes, spontaneous recovery. You have evidence of sulcal hyperintensity on flare, which tells you that this could be subarachnoid hemorrhage, and you have these irregular vessels. How do you put this constellation of findings together in calling it what you want to call it? So we will call it as RCTS, right? It is a typical appearance of the vessels and the clinical pattern and the presence of subarachnoid hemorrhage. So the take-home message is there are 5 well-defined and easily identified. Easily identifiable is doubtful, but there are identifiable stages of evolving hemorrhage as seen on MRI. Knowledge is important for dating single hemorrhagic event and to ascertain if multiple hemorrhagic events have occurred at different times. CT may be useful than MRI in detecting hyperacute parenchymal hematoma and early subacute hemorrhage. But MRI is certainly more sensitive after 12 to 24 hours and more specific in determining the age of hemorrhage and its etiology. Thank you so much. There are many questions.
Hemoglobin, then methemoglobin and all the other degradation products. And then the intactness of the RBC membrane, whether the products are intracellular or extracellular. If we are strong on these basics of diamagnetic, paramagnetic substances and the various degradation products of hemoglobin and how they influence the signal on T1 and T2, as Sir has shown, I think we should be able to come to a conclusion. And then we are also thankful to you, sir, for taking us through some of the primary and secondary causes of intracellular fatigue. I would request Mr. to make a few valuable comments.
Thank you, sir. It was a wonderful lecture with explanatory examples. I only request the postgraduates to, as sir has told, to go through the stages of the blood by their chemical composition, like oxyhemoglobin, deoxyhemoglobin, intracellular methemoglobin, extracellular methemoglobin, hemosiderin, and ferritin, rather than I know there are many postgraduates here, they remember this bleed as something like an hippie, whippy, dodo, BP is the one thing. And unfortunately, one day when I was sitting with my postgraduate, not in this medical college, I asked her and she told, boss bleeds, boss dies. Unfortunately, I was the head of the department there. I told, please don't lose these things. It is better that we understand, otherwise I was a bit polite boss. If a really strict boss is there, you had it in your exams. Thank you. Thank you.
Thank you so much. Already consumed all my time, so I'll
when you're speaking about bleed in the brain, as a neurosurgeon, we encounter cavernoma bleeds. Can you just suggest us the acute bleed case when it arrives in the emergency with the MRI imaging done? Because for all brain emergencies, we usually prefer going for MRI first. When doubt arises, then we go for CT. So, can you suggest some light? Anything, how to differentiate a cavernoma? Can you give us any clue in the first MRI itself? Our suspicion.
So one of the things, so in acute stage,
the world, you are going to know that it is a bleed in the cavernoma. Whether you do CT, whether you do MR, whether you do contrast, there is no way for you to know. The only way for you to know is that if it has incompletely bled, that means the entire cavernoma is not reticule other lesions. So these are the only two ways to know that it is not a bleed within the cavernoma. Otherwise, there is no way to know, and you have to just wait it out and do a follow-up imaging when the blood clot shrinks to know that there is a complete hemosiderin rim around it and the hemorrhage was indeed within the cavernoma.
If it is the first time bleed, it is
Sets of images that any vendor provides. One is called the magnitude image, which are the conventional appearance of a T2 star or gradient echo image, where dark things look dark. Whether it is blood, whether it is calcification, those things look dark. But there is another set of image which is called phase image. Now, this phase image are exactly, I would
like ADC
put it simply,
diffusion.
they are the inversion image of the SWI image, but physically they are not. Physics-wise they are not. I should not say physically. Physics-wise they are not. What they allow is if the pathology looks bright on those images, then it is unlikely to be hemorrhage and is calcification. If the pathology looks dark on both these imaging sequences, then it is likely to be blood. Now, it is good to say this in conferences, and when you are giving a didactic talk like this, it is very easy to say, does it always work? Does it replace CT? The answer to that is no. The more gray hair you grow, more problems you realize. So it is not 100% true. Many times what looks dark on both images does turn out to be calcification on CT. So it is not that it works every time, but it is worthwhile looking at those set of images. At least what is looking bright on the phase images is not going to be hemorrhage for sure, right? But the converse may not be always true.
To give mementos to Dr. Raghunandan Nardik, sir. Vinil, Dr. Atre, sir. Sir, to give mementos to chairpersons, Dr. Rudresh sir and Dr. Ramakrishna sir. To the next presentation. For this, I would like to invite Dr. P.S. Reddy sir and Dr. Deekshanti Narayan madam to chair the session.
Thank you. Good morning, everybody. At the outset, I am honored and has the greatest privilege to be in this lovely place with my friends, Dr. Sampath, whom I have traveled for more than 20 years, and Dr. Ramana Murthy. Thank you for inviting me for this. I thank the Almighty for giving me this opportunity. It's a very, very broad topic, so I'll try to show you the first, then what is the lesion, and then where is it. This is a basic dictum. The lecture might look primitive, but this holds good for every one of you at every state, any state of your practice, because previously the so-called functional cases were diseases of exclusion. Now it has completely changed. There are no more diseases of exclusion. There are standard sets of clinical tests which would evaluate functional neurology. There was a big conference going on functional neurology cases, and what are the clinical stages of identification of functional hemiparesis, or the case of functional, the visual loss, or everything. Everything is set of clinical tests how you identify a functional case. So there are no more diagnosis of exclusion. So first thing you must ascertain that is there a lesion. Second thing, what is the lesion? Most often I find that youngsters, they jump into the what is the lesion is the third step. Second is where is the lesion. Say what is the etiology? Where exactly it is located in the neuraxis. Once you locate where exactly is the neuraxis, it's easy for you to determine the etiology. So here comes, the famous dictum, Occam's razor versus Hickham's dictum. One said, you can, if for example, multiple places in the neuraxis are involved, this fellow said, you should have only one diagnosis. Try to put everything into one place. For example, an optic nerve, one lesion in the optic nerve, one lesion in the floor of the fourth ventricle, one lesion in the spinal cord. Okay? So neuromyelitis optica. He wants to put everything in one basket. Plurality is not allowed in, it's not allowed in medicine. That is one concept. The other one is diseases don't follow the textbooks. They can manifest. Two diseases can coexist. So I don't mind putting everything in one diagnosis. For optic neuritis, I have one diagnosis. I have one diagnosis for spinal cord and one diagnosis for. So these are the two diverse concepts in neurology which evolved, and most often all of us look into putting everything into one single basket. That would decide what is the etiology, what is the lesion. So once you identify where is the lesion, then go into what is the lesion. Don't jump into what is the lesion before you identify where are the lesions located. That's the first most important thing. And second thing is, most of the algorithms of every clinician is based on these three things. The onset, duration, and progression. These are the three most important things by which you decide. Onset can be instantaneous. Next second he is paralyzed, or minutes, or it can be in days, weeks, insidious, years. So similarly, duration, acute, few days, and subacute is few weeks, and chronic is months. Progression, is the lesion progressive, is it regressive, is it static, is it fluctuating, is it episodic? These three, whenever you start your presentation, I always insist that onset, duration, and progress are the three most important things. This is all essentially meant for the residents, and please apologize me for if it's at a very primitive level for the consultants. So as you know, the various parts of the neurasthenics, you should be aware starting from the cortex, subcortical, the thalamus, capsules, thalamus, brainstem, subsequently the spinal cord, anterior horn cell in case of motor, or the dorsal ganglion in case of sensory, and then the entire lower motor. For example, in motor, you will start with the anterior horn cell, it comes out through the ventral root, it joins with the dorsal root, forms the spinal nerve, then that divides into anterior and posterior primary rami. The anterior primary rami forms the plexus. You will understand that brachial plexus name, it's a misnomer. The roots in the brachial plexus is anterior primary rami, not the anterior root. So the anterior primary rami, plexus, and then the plexus gives rise to various peripheral nerves, and nerves gives rise to neuromuscular junction, and neuromuscular junction, muscle, and within the muscle, the mitochondria. So LMN always take into mitochondria also into account so that you don't miss mitochondrial lesions as part of your etiology. So in cognition, it's always, the black and stuff, the chapters are arranged in the same sequence where you have to examine, then only it will be useful to you. It always starts with the level of consciousness, attention, language, memory, constructional ability, higher cognitive functions, related cognitive functions like praxis, gnosis, and visuospatial orientation. And whenever you look into the cortical lesions, also look for the behavioral domains. So there are 2 domains. Look for the 10 cognitive domains and then look for the behavioral domains. The behavioral domains would be starting from the physical demeanor, how you look, or sitting on the edge of the chair, or that kind of things, and mood. Then the emotions and thought. Thought is what is the thought? What is the content of the thought? Is thought mixed with illusions, delusions, or hallucinations? And is there any other non-psychiatric emotional disturbances? Are there any compulsive behavior? All this come under the behavioral domain. So neurobehavioral examination, cognitive and behavioral domains should be part of your higher mental functions before you come into the diagnosis. So previously it's all substrate based. Now there are no more substrates. Substrates are all gone now. Now after the advent of the functional MRI, the advent of network imaging, I am sure that neurology is going to be rewritten. In fact, neurology requires to be rewritten because whatever we were taught in our colleges are now completely, a lot of things have changed in neurology. So the networks are, you can see the major networks are now the sensory motor network, the default mode network, the salience network, the limbic network of emotion, the dorsal attention network, the central executive network, and the visual network. So these are the major networks, and in the networks also there are different schools of thought. Marcel Mesulam divides into 5 major networks, and all other things he puts as a sub-network. But this is the one which has come to standard. The other sub-networks would be ventral attention network, language network, and the auditory system. And you'll know this is the pathway. All of you will be aware from starting from the precentral gyrus up to the ventral horn, the various pathways and how does it cross in the pyramid, and uncrossed fibers form the anterior corticospinal tract, and then the next part would be the various corticobulbar pathway. All of you are aware, and this is just to brush your knowledge on the thing, and the same thing which I told you, the ventral root, dorsal root, you'll see the spinal nerve, and then the ventral primary ramus, and then that forms the plexus, and then the nerves, and then goes to the neuromuscular junction, the spindles. So let me take you into few of the case scenarios where it will help you into localization. A 71-year-old female presented with failure to recognize reflected self-image, resulting in conversing with the images. Fights suspected reflected self-image is abnormal. Did not have prosopagnosia, able to identify husband, all the familiar faces, everything she is able to identify. Just watch this. She goes to the meter and sees her own image and short fights. She feels that she has stolen her necklace. And because she says all the time that lady is peeping into my room, she has covered the glass with she becomes very violent. You come, I'll see, I'll kill you. That kind of a, so see what happens is the only image which we don't perceive is our own image. We have never perceived our image. We don't know what it is. What we see is only our reflection. Whatever the mirror reflects, if the mirror has a concavity in the middle and your image is designed, that is the image which you have for your own self. So the truth is that the one image which you have never seen in your life is your own image, and you're dependent upon the coordinates provided by the reflection of your image on the mirror. If the defective mirror means a defective image your brain would store. So that is, this is called mirror agnosia. The mirror agnosia has two types, mirror and mirror agnosia and mirror image agnosia. Mirror image agnosia is she doesn't even respect, identify that it is a mirror, but whereas mirror image agnosia is, she knows that it's a mirror, she can identify all others' reflection in the mirror. Only problem is with her own image. This is what this lady had, mirror image agnosia. So as you know, gnosis is a modality-specific ability to access semantic knowledge of an object or stimulus in the presence of normal perception. Normal perception is very important. Inability to access the semantic knowledge and identify what it is in presence of a normal perception is called agnosia. So this is one type of agnosia. Failure of this is agnosia, is a disorder of recognition. You are able to perceive. You have to, when you say that the patient is an agnosia, you have to establish the percept is normal. The percept is normal, only the interpretation of the percept is at difficulty. The self images are different from others. None has seen their own image. Failure to recognize this image can be labeled as mirror image agnosia or prosopagnosia for self-reflection. Prosopagnosia is the inability to identify faces is called a prosopagnosia. We identify faces not only by the face. The moment you see a face, it invokes some emotion into you. When you see your mother, it evokes a reaction. When you see your girlfriend, it evokes another reaction. So this emotional component is also important, and you know that all of you know that the facial perception is in the face area in the lingual area, lingual gyrus, and the adjacent gyrus. The lingual gyrus, the face fusiform area of the occipital cortex is the place where you have the face perception. The more on the right than one bilateral, and the adjacent gyrus is the lingual, which passes the emotion onto it, connected by a U fiber. So face is performed in the fusiform gyrus. Emotion is imparted to that from the lingual gyrus, which is just adjacent to that. The disconnection of this would result in you will identify the face and say this looks like a mother, but it's not my mother, because the emotional component is missing, and that is what the psychiatrists have been treating it as for many years as Capgras syndrome. Now we know it's Capgras syndrome is only a disconnection syndrome between the identification. The face was perceived, the face did not kindle the emotion of the mother, and so the person feels that it is not my mother. It is mother, but looks like my mother, it is not my mother, because the emotional component. The same person identifies mother by her voice. When the same person says, this is the voice of my mother, because that U fiber is from the temporal gyrus is different. That root is different, where the voice of a person evoking emotions is also equally different. So this is how you go into the localization of this. So coming back to this case, you see that she was fighting for real objects inside that. That is the differentiating point, argues with the reflected self face, is the one which is present in this case, and this is a case of mirror image agnosia. So the body schema is in the non-dominant parietal lobe. Once you identify that this domain is agnosia, this domain is controlled by the non-dominant parietal lobe, and then you take it up the localization from there. So there are a lot of, I don't want to go into the details, a lot of completely different things are there. Highly specialized neural circuits deal with the reflected self images, very, very common in posterior dementias, especially posterior predominant Alzheimer's. And then we'll go on to, sir, how many minutes I have, sir? Just can you, because the inauguration and all is there, can you, 30 minutes, just let me. Okay. Then I And initially when I was a student like all of you, I always felt the brainstem is so complicated until I realized that's a very beautiful highway, so well organized. You can see on the top the motor is in the center, the sensory is there. You can see the somatic, the special senses and the visceral are organized on separate lanes in the highway. Similarly, on the motor also, you can see there are few nuclear areas in the brainstem, like your wayside motels, the highway constructions. The highways are all white matter tracks. The toll gates, pit stops, the coffee shops are nuclei containing cell bodies, which are cranial nerve nuclei, can be visceral nuclei, anything. The knowledge of the precise anatomical localization of the lesion is very crucial in the brainstem localization in neurological familiarity, and the highway constructions. If you see this, the alar plate and the basal plate is motor, the basal plate is ventral, and the alar plate is dorsal. So you know that ventral is motor in the spinal cord, and dorsal is sensory. The same thing holds good, but because when ventricles start enlarged, what happened was the alar plate starts occupying the lateral position instead of the pure dorsal position. Instead of the pure dorsal position, they just came out. From the dorsal position, they migrated outwards. So all in the brainstem, the lateral portion is all fully sensory. The medial portions is essentially motor. The paramedian and the paramedian portions are all essentially the motor highways carrying the various ascending and the descending motor tracks. The lateral one is so. In brainstem, ventral is, if you have a corticospinal tract involvement, the lesion is ventral. If you have a sensory involvement, obviously sensory is going to produce ataxia. Ataxia can be cerebellar or posterior column involvement, or the posterior column as it ascends up the lemniscus. So the dorsal one would be ataxia, and motor weakness will be ventral. So ventral and dorsal. So this is a basic thing when you localize things in the brainstem. And if there are special senses are involved, the lateral most column in the highway is the last lane is a special senses lane. So and then the midbrain is again the one which is ventral to the dorsal to the center tract is called the tectum. The one in the ventral portion is the base, and the tegmentum is in between. So the rule of 4, which is for the as I told you, motor pathway, medial longitudinal fasciculus, and motor nuclei and nerves are all the midline or the paramidline structures, and the 4 sideline structures, spinocerebellar tract, spinothalamic tract, sensory nucleus of 5th, and sympathetics are the 4 side structures. Cranial nerves, yes, I'm sorry. So medulla 9, 10, 11, 12, the cranial nerves 5, 6, 7, 8 is in the pons, and 1, 2, 3, 4 is above the pons, and where the 1 and 2 are not part of the brainstem. They go, the one, that the one goes, the olfactory goes through the cribriform into the prepiriform cortex through a different pathway, and the optic nerve also has a different rule. So in essence, based on the cranial nerves, 3, 4 takes you to the midbrain, 5, 6, 7, 8 will take you to the pons, 9, 10, 11, 12 will take you to the medulla. So we have talked about what is ventral in the brainstem, what is dorsal in the brainstem. Based on the cranial nerves, you know whether it is pons, midbrain, or medulla. So I'll show you. These are the major highways transferring across the brainstem. The corticospinal or the bulbar tracts, spinothalamic tract, trigeminal lemniscus, medial lemniscus, reticulospinal, rubrospinal, and the minor state highways are just within the. So what is the major highways is starting from spinal cord, goes up to the cortex via the brainstem. Whereas there are few tracks which are confined only to the brainstem. Couple of examples is, one is the medial longitudinal fasciculus, which is only within the brainstem, starting from the ipsilateral 6th to the contralateral 3rd. It starts and ends within the brainstem. So you can call it a state highway also, small highway which is within the brainstem. Ventral tegmental tract. These are the three common examples of small minor highways. So major highways, descending tracts, the corticospinal tract, the classical pyramidal tract, all the extrapyramidal tract like reticulospinal, tectospinal, rubrospinal, vestibulospinal, and the last one is very small. What is the last one? I am not able to see this. Olivospinal tract. So these are the tracts which are present in the major descending tracts. Coming to the major ascending tracts, the spinothalamic tract, trigeminal lemniscus, medial lemniscus, lateral lemniscus, auditory lemniscus, ascending reticulofibers, and other minor tracts. There are two A tracts which I already told you. One is the medial longitudinal fasciculus, which controls the head-eye movements, and the dorsal longitudinal fasciculus extends from the hypothalamus to this. So the minor highways are restricted to the brainstem. Majority of the described fibers are concerned with eye movement. And the central tegmental tract, which is part of the Guillen-Mollaret triangle, which is with the opposite red nucleus. CTD connects the red nucleus and the inferior olivary nucleus. Lesions affecting this produces the palatal tremor or the myoclonus. So coming to the ventral tegmental tract, which connects the superior vestibular nucleus to the cranial nerve 3, especially to the superior rectus of the selectively elevators of the eye. The tonic firing of the superior vestibular nerve through the VTT negates the effect of the gravity on the eyeball. So lesions affecting the VTT result in upbeat nystagmus. Whenever you have an upbeat nystagmus, you will suspect this. So this is commonly affected in Wernicke's encephalopathy or any case of demyelination. So we will now look into how do you localize this in the brainstem. The localization can be in the vertical plane or in the horizontal plane. Vertical plane, as I already told you, by the cranial nerve deficits. You know what are the cranial nerves in the medulla, what are the cranial nerves in the pons, and what are in the medulla, in the midbrain. The lesions are always ipsilateral in the cranial nerves. In the trochlear nerve, the lesion is contralateral to the side of cranial nerve defect, which you should know. The only exception to that. And in the horizontal plane, corticospinal tract and medial lemniscus are ventral and medial. The spinothalamic and the descending first order sympathetic neurons in the cerebellar peduncles are dorsal and lateral. And that is why you know that in lateral medullary syndromes you have a harness on the since they are situated laterally, the harness is on the lateral medullary syndrome. Harness, the descending autonomic fibers involves results the first order neuron defect in the producing a harness. And similarly you have the hemisensory syndromes. With the exception of the caudal medulla, the proprioception vibration of the lesions will be contralateral to the hemisphere, whereas after the sensory decussation, it will be ipsilateral. So then you have to identify whether it is intraaxial or extraaxial. The features which suggest intraaxials are presence of Horner syndrome involving the first order descending fibers from the hypothalamus to the intermediate horns in the cervical region. The INO, which is the lesion involving the medial longitudinal fasciculus, crossed pattern of weakness, ipsilateral cranial and contralateral paralysis is again suggests it's an intraaxial lesion. Crossed pattern of sensory loss, similarly ipsilateral face and contralateral trunk, which is a harlequin pattern of sensory loss which you observe in medulla. The onion peel pattern of the facial sensory, which involves because of the involvement of the spinal tract of trigeminus. Dissociation between the motor and sensory components of fifth and long tract signs. These are all the signs to say that the lesions is intraaxial. And I'll go take you through few of the localization cases. 30-year-old male brought with the complaints of acute onset of weak nerves of left upper and lower limb. One day, examination revealed, you can see the ptosis, unilateral but not bilateral. I'll come back to that. You can see the ptosis is there, and look at the pupils are dilated, and the pupillary involving third nerve with the left hemiplegia. So right eye ptosis, elevation and adduction defects with mydrias in the right eye. Right third fascicular palsy. Why I say, see, normally in fascicular palsy or nuclear palsy, you expect bilateral ptosis In fascicles, very close to the nucleus, it can have a bilaterality, but lower down near the in the cerebral peduncle, there can be unilateral ptosis alone. And in midbrain, there can be selective subnuclear involvement also. As you know, there are 5 subnucleus are present in the brains. The third nerve nucleus complex has 5 subnuclear component, and so ipsilateral third nerve and contralateral hemiplegia. So cranial nerve palsy, long tract signs says that the lesion is intraaxial. Third nerve fascicular palsy says it is midbrain, and corticospinal tract says it is ventral. So it's a right ventral midbrain lesion. The lesion is there, Weber's syndrome. All of you know about that. Similarly, the lesion, I have shown you the lesion involves the fascicle, the oculomotor nerve fascicle within the brainstem, and the corticospinal tract in the cerebral peduncle. So just to highlight you that the sympathetics produce the mydriasis and parasympathetic produces meiosis. So paralysis of the parasympathetics would result in mydriasis of the patient. Pathological anisocoria is always an efferent problem, and that is beyond. So next case we take you, 54-year-old male brought to the acute onset of drooping of the left eyelid, swaying while walking to the right side. Examination revealed the following: complete ptosis, left eye, and right eye shows, your finger nose in coordination, and he had a right eye, there is no weakness. Patient didn't have any weakness. Left eye, third nerve, right side of the ataxia, no weakness. So cranial nerve plus ataxia says it is intraaxial. Third nerve involvement says it is midbrain. Ataxia says it is dorsal midbrain. So left-sided dorsal midbrain. Ataxia is in midbrain, involvement of the brachium conjunctivum, that is the superior cerebral peduncle. The ataxia is contralateral. So this says it's a left dorsal midbrain lesion, the Claude syndrome. So this is where exactly the lesion is present. Then what are all the midbrain syndromes with third nerve palsy? If you really at the 3 syndromes which you all know, ventral midbrain, the Weber's, ventral midbrain and midbrain tegmentum is Benedict's, ventral midbrain tegmentum is Claude. I have shown you Weber and Claude. The Benedict syndrome is the involvement of the red nucleus which is in the middle, which is situated in the tegmentum of the midbrain, and the presence of that. So it produces ipsilateral third nerve, contralateral hemiparesis, and tremor. So in Claude syndrome, there is no involvement of the corticospinal tract, so there is no weakness. It's only ataxia and ipsilateral third nerve, which you have already seen. So these are the various subnucleus, and this is exactly where the lesion was situated. So in essence, between the nucleus lesions versus the nerve lesion in third nerve, the nucleus lesions produces bilateral involvement ptosis and bilateral impaired elevation. All other things are similar to both the nerve. So whenever you have a bilateral ptosis and a bilateral elevated defect, you strongly suspect a nuclear lesion. Look at this. What does he have? Anybody? Patient has got you can see a conversion retraction nystagmus. Conversion retraction nystagmus immediately should make you think the accommodation is situated in the dorsal midbrain. The center is located in the rostral dorsal midbrain, up-gaze palsy, and convergent retraction nystagmus dorsal midbrain. Classically, so the gaze palsy intraaxial, up-gaze is in the midbrain, and convergent retraction again says it's dorsal. So dorsal midbrain, in fact, it's called Perinaut syndrome. So to summarize, we have talked about the Perinauts, we have talked about the Weber, we have talked the Benedict's, we have talked about Clatz, and the last one is the Nathaniel, which is ipsilateral or bilateral third nerve with oculomotor palsy and ataxia. Usually, it's usually neoplastic. So these are the 5. So now you know at least roughly how to identify this intraaxial, extraaxial, identify this ventral or dorsal, identify whether it is pons, midbrain or medulla. So this is I feel the brainstem localization is absolutely like mathematics if you are thorough with the anatomy. So this I am going to, sir is our beloved professor James sir is here, James Jose, who is an authority on spinal cord. I have enjoyed his talk many times and I was fortunate to be associated with him, and the book which he has written on spinal cord, I wish every one of you should read that book. It's a beautiful book on spinal cord localization, and the second book is no lesser in the cognitive higher function domain. So you are fortunate to have him utilize his knowledge. So I think he's going to have a case discussion next, no sir? So the 23-year-old male patient, 3rd degree consanguineous parage, normal birth history with unsteadiness while walking and stiffness of both lower limbs. Patient had difficulty to grip slippers for the past 3 years. Past 2 years, the patient noticed that he was tripping over small objects due to stiffness. Poor scholastic performance. Tonic-clonic movements of the upper limb, lower limb with tongue bite 1.5 years back. What is important here, you know that there is definite history suggestive of a corticospinal tract and inherited with seizures and cognitive involvement. Clinical examination revealed normal cognitive assessment, no cranial nerve deficits. Motor system hypotonia, reflexes brisk, both lower limbs, bilateral extents of spastic gait. So here is a case of spastic quadriplegia, lower limb more than upper limb. Investigation showed a normal hemogram, but the vitamin B12 levels were very low. On evaluating further vitamin B12, the serum homocysteine levels were found to be high, serum homocysteine level more than 50. If you look at this is the image. The image showed patchy T2 hyperintensities involving bilateral occipital, periventricular white matter with confluent T2 hyperintensities involving bilateral centrum semimobile and frontal deep white matter. MRI thin and nerve conduction studies were normal. No posterior column involvement at all. So this looks like family history, strong family history there. B12 deficiency is there, but doesn't have the classical subacute combined degeneration like picture. Imaging was normal. So we, in view of family history, we worked out to find out that we looked for a inherited myelopathy. One of the causes, the leukodystrophies, hereditary spastic paraplegia genes. The entire panel we sent, the MTHFR gene came to be positive. Methylene tetrahydrofolate reductase deficiency, treated with B12 high doses and B6. On an initial follow-up, patient showed improvement of the gait. In adults, patients familial gradually progressive spastic paralysis, homocysteine levels should be elevated. Even though the MTHFR deficiency is rare, it should be. So in case of spinal cord, when you look at the myelopathies in the family history with the spinal cord is there, see, you must think 4 groups of diseases are there which are present. One is the spinocerebellar ataxias can be there with the involvement of corticospinal tract. Motor neuron disease can be there, which is inherited with the spinal cord involvement, the corticospinal involvement, and the leukodystrophies. Here comes the view of the treatable ones, where the subacute combined vitamin B12 deficiency, the MTHFR gene defect, and cobalamin C deficiency, multiple sclerosis, the demyelinating syndrome, adrenoleukodystrophy, where you can use Lorenzo's oil. So the most of these leukodystrophies, most of them have some or other treatment available. The last one is the distal nervous. The 4th syndrome is the distal central nervous system predominant distal motor sensitive neuropathies, where this hereditary spastic paralysis. So HSP, leukodystrophies, motor neuron disease, and SCA are the 4 groups of inherited myelopathies which you should think of whenever there is a myelopathy with a family history. So this is another similar patient which we recently had, 25-year-old male patient. This patient had memory disturbances, extrapyramidal, 1.5 months, and the only thing which was his vitamin B12 levels were 40. You can see the image. Again, the white matter intensity in the brain, nothing in the spinal cord. So remember, vitamin B12 is a masquerader of anything. The megaloblastic madness which we used to see in those days, which was present with bizarre clinical manifestations. Even bladder involvement can also happen in few of the cases. So you can, for anything and everything, always investigate for B12 because it's a treatable case. So 63-year-old right-handed diabetic hypertensive, past history of CAD, sudden weakness of left lower limb for 6 days ago, right lower limb weakness, 5 days duration, treated in a local hospital, asymmetrical leg weakness, left more than right, intact touch pain sensations, no sensory level, reflexes exaggerated in both the lower limbs, plantar, extensor, bilaterally, urinary incontinence. So, in complete spinal, sorry is going to, so I don't want to go into the details. There is, you always remember in the complete central cord syndromes, you will have a trunkal level. Sometimes definite level will be there in the trunk and involvement of all the tracts, posterior spinothalamic and the corticospinal tract, all will be involved. So, in a complete cord syndrome. Whereas, in a hemicord syndrome, the brown sequoia pattern of sensory loss where ipsilateral dorsal column and contralateral spinothalamic will be, and or the central cord syndrome where you have a syringomyelia is a prototype disease where you have a suspended sensory loss, or anterior cord syndrome due to a spinal artery occlusion where the posterior, the dorsal columns are spared. So, in this, coming back to our case, we carefully looked for a cortical sensory loss. They were lost in the lower limbs. So, tactile localization, graphicy, even though the primary sensations were all intact, that took us to the cortex as a lesion, then looked for primitive reflexes were all present. And in a case of sensory deficit, brain can be cortical sensory loss, which you said stereognosis, the graphesthesia or the 2-point discrimination on all. The subcortical sensory disturbances can be coronaradiator or the internal capsule, the thalamic sensory loss, brainstem, again midbrain, pons and the medulla have different patterns of sensory loss. Spinal cord, as I already told you, cervical has a different pattern, thoracic, lumbar, and the nerve in the lower sensory one, it can be a radicular pattern of sensory loss, polyradiculopathy pattern of sensory loss, DRG root pattern of sensory loss, plexus mononeuropathy or mononeuritis multiplex pattern of sensory loss, polyneuritic pattern of sensory loss, or among the fibers it can be small fiber or large fiber. Not to forget you can see the diagrammatic representation of this. It can be a hemisensory pattern, or it can be a harlequin pattern, or it's a truncal level, or it's suspended, or distal glove and stocking pattern of sensory loss, or brown sequoia pattern, or a radicular pattern. Do not forget the 3 types of special things are the sacral sparing, saddle anesthesia. Do not forget that. Always examine in sensory. Never forget to examine the sensations in and around the anus. So, you all should be familiar with the various dermatomal pattern and various peripheral nerve patterns of the sensory. So, this pattern coming, our case had a bilateral ACA stroke which was responsible for the lower limb weakness with cortical pattern of sensory loss. Case minute. Last case, 28-year-old previously healthy woman presented to the emergency department with evaluation of weakness of all 4 limbs, fatigue, back pain, painful paresthesias, no objective finding on day 1, felt limbs were heavy, slippage of slippers, hand grip became weak, difficulty in breathing, fever, chills, the single breath count 14, bilateral LM and facial labs, symmetrical flaccid weakness of all the 4 limbs, no fasciculation, normal sensations, so areflexic flaccid quadriparesis. Where do you localize? What is the lesion? The commonest lesion would be the AADP, which is a GBS like presentation, flaccid weakness, flaccid, diminished absences or reflex, and flexor response in the feet. So, in LM and weakness, I just wanted to say anterior horn cells, the weakness is, the wasting is disproportionate to the weakness. Wasting is more, weakness is less if there is an anterior horn cell and presence of fasciculations. That will tell you in the root, there is a root, if the dorsal roots are involved, there can be a radicular pattern of finding and fasciculations may or may not be present, and if both the dorsal and the ventral roots, you will get the radicular pattern of sensory loss. In contrast, in muscle, if you look at it, the weakness is more not in pari passu with the wasting. Wasting is very, very less in muscle, but the weakness is gross. So, that is how you differentiate an anterior horn cell with a motor, with the muscle weakness. So, anterior horn cell, muscle and the neuromuscular junction are purely motor, and whereas the radicals depends upon the involvement of dorsal radical or the ventral radical can be mixed. Plexus also can have a sensory loss. The peripheral nerves, if there is sensory motor nerve involvement, can be sensory. So, pure motor would be the neuromuscular junction, muscle, and the anterior horn cells. which are differentiated by the basis of various patterns of. So our cases, so this is a summary of the various LM and weakness, which I already talked. So our patient had a flaccid. So cerebrospinal fluid, nerve conduction study, toxin screens, AADP, diphtheria is a descending pattern. Lead, do not forget. Porphyric serial, don't forget. Tick paralysis and snake bite. Thank you for your attention.
The session is open for discussion. If any queries, please ask.
It's a very broad topic.
We have convergence retraction nystagmus in Peri-Nord syndrome because convergence, both medial recti fired together because the lesion is in the midbrain, both medial recti fired together, so we have convergence. There's no divergence because pons is intact. Why do we have retraction? Both superior rectus and inferior rectus fire together. So there is both superior rectus and inferior rectus firing together. So we have retraction, both medial recti firing together, so we have convergence. This goes against the law of Sherrington's law of reciprocal innervation, wherein when agonist contracts, antagonist should relax. But here, both superior rectus and medial rectus are firing together. So what is the explanation? It is a supranuclear palsy which does not obey the Sherrington's law of reciprocal innervation. Thank you, sir.
Yes, sir. You want to add?
One more addition to that. Convergence retraction nystagmus is actually not a nystagmus. It won't comes under the definition of nystagmus because it has no slow component. All nystagmus should have a slow component. The upward movement is replaced by a sudden jerky movement. That's all. So it's actually, even though we call it as nystagmus, it's not a nystagmus.
It classically does not fall into the classical nystagmus, even though it is conventional.
Regarding Capgras syndrome, you said it is a disconnection between the fibers going from the lingual gyrus and the fusiform gyrus. But we see commonly in Alzheimer's disease and Lewy body dementia. So you mean to say there's a disconnection between the lingual gyrus?
Component, there is it's a part of the disconnection of U fibers from that area.
Excellent presentation with good examples, sir. Sir, I would like to know, sir.
Yes,
sir, regarding a case example of mirror image agnosia, what was the final diagnosis?
She had a dementia, Alzheimer's, posterior variety of Alzheimer's.
Oh, okay, okay.
She had a posterior variety of Alzheimer's, and very pretty early.
Okay.
In fact, she is wife of a priest in a temple.
Mm-hmm.
The one that is why she has in fact come with ER department image agnosia, and she came to us with this finding.
Okay, okay, thank you.
And finally, PET proved is a posterior predominant Alzheimer.
Yes, yes, thank you.
Thank you. Thank you.
Sir, Dr. Vishwakumar, sir. Medical Superintendent, sir. Dr. Hariprasad Reddy, sir. Coordinator of Narayana Medical Institution, Dr. Biju Ravindra, sir. APNSA President Dr. Babji, sir. APMC Medical Observer Dr. B. Srinivasal Reddy, sir. Organizing Secretary Dr. N.S. Sampath Kumar, sir.
Dr. Sampath Kumar sir has made lot of efforts for this event to happen today despite many hardships. He is an esteemed HOD of Department of Neurology, Narayana Medical College. We are very grateful to you, sir. He is a renowned neurologist who established himself as one of the leading experts in the field of neurology. As head of the department, he keenly indulges in the clinical, academic and research activities of the department, ensuring excellence in patient care, delivering compassionate, cutting-edge care to patients with neurological disorders. Now, I request to welcome them with the planned bouquets. Song.
The lamp of enlightenment.
అందరూ ఒకసారి రెడీ ప్లీజ్ సార్ రెడీ వెయిట్ సార్ వెయిట్ సార్ ప్లీజ్ సార్ కొంచెం ముందు సార్ వెయిట్ సార్ వెయిట్
but also to the continued education and inspiration for the next generation of leaders in our field. This gathering represents an invaluable opportunity for all the coach perspectives and build meaningful connections that will enrich their professional journeys. Now, without any delay, I request our principal sir, Dr. Vishwakumar sir, to address the gathering.
And I'm honored to be here, joining this occasion to address you. And I look forward for the fruitful discussions and collaborations, and it's a great opportunity and avenue for the postgraduates for interaction with the senior faculty and enriching their knowledge and honing their skills. Definitely, this being the congregation of stalwarts in the neurosciences, it's a perfect avenue for the postgraduates where they can see confluence of academic excellence with the clinical skill. And I hope, I expect all the PGs to actively participate in this and derive maximum advantage of this. And I hope it's going to be a beautiful academic feast for all the participants. And I appreciate efforts by HOD Anatomy Dr. Sampath Kumar for painstaking attempts to organizing all these things and bringing it to one platform for the congregation. Thank you.
Now I request our medical superintendent sir, Dr. Hariprasad Reddy sir, to address the gathering.
Good morning all. It's a warm welcome all the delegates all over India to NELLOR. Respected dignitaries on the dais, our Vice Principal Vishwakumar Garu, our Narayana Medical Institution's Coordinator Dr. Biju, then Professor and HOD Sampath, and Indian Neurological Association of Lakshmi Narasimhan Garu, and all the eminent faculty and delegates across India. And glad to hear that around 200 registrations have come, and it's a wonderful scientific program over 2 days. So mixed with all the eminent speakers are there and doing the workshop, and both neurology and neurosurgery together, and for all the useful for the residents as well, and also interaction with eminent faculty across India. All are experts in their field. So it's a very good scientific program design, and welcome you all. And Narayana Specialty Hospital, so started in 2006. It is a 1560 multi-speciality hospital with all well equipped with infrastructure, especially the Department of Neurosciences, the Professor and HOD Dr. Sampath Kumar. So he takes active interest in both academic activities and clinical program. So under neurology, we got, apart from the regular stroke and epilepsy clinic, so I got a unique Narayana comprehensive epilepsy program, where so intractable epilepsy patients are identified, and they're doing epilepsy surgeries also under Arogyasri. We're the only center in AP and Telangana. Very few centers are doing across India. So Dr. Sampath and our neurosurgery and our team is there. Dr. Sai Kiran and Vidya Sagar and Dr. Ravish is the program under this program. We have done more than 55 epilepsy surgeries here, and it's a ongoing program. And also we have got a exclusive, apart from the regular neuro unit, we have gotten a round-the-clock 10-bedded neuro ICU with round-the-clock expert specialist care. And our neurosurgery theatre is a state-of-the-art modular theatre with all neuro navigation system and with all equipment, camera and all these things. And apart from the regular trauma, our neurosurgeons do intracranial tumors, aneurysms, and regular spine surgeries, minimally invasive spine surgeries round the clock. And we got an exclusive 12-bedded neurosurgical ICU backed by expert anesthetist, and we're doing ultrasound-guided blocks and foraminal blocks, all this. We have got all the residents are well-trained, and as this CME is rightly apted, like with clinical excellence and academic excellence and clinical expertise. So I got this wonderful opportunities. Our residents do well, and hope all the delegates who have come here will have a good academic feast, and also have a culinary of especially of Nellore. Hope you'll all enjoy the stay and have a good academic expertise, and have interaction with all the faculty here and with all the experts in the field. Thank you very much.
Thank you, sir. Now I request APNSA President Dr. Babji sir to address the gathering.
Good morning, everybody. It's a wonderful program of neuro clinics started by the APNSA, and I think this is the third thing which we started. This first in Guntur, next in Kakinada, and now in Narayana Medical College, Nellore. And I must thank Dr. Sampath and Dr. Ramanamurthy for taking all the pains. And it was looking like a mini state conference. So all people in good mood of learning, and stalwarts have come for these neuro clinics. In the beginning, we thought neuro clinics means only case discussions, but it has been extended, and I am extremely happy that all the students and the junior and senior teachers are also learning from these neuro clinics. And neurology and neurosciences are like mathematics. So I remember even today, the neurology is like mathematics, and I enjoy hearing and reading the neurology. I still remember my teachers of neurology, neurosurgeon Dr. Bhavara Subbarao Garu used to teach us neurology, and that is the one which all the neurosurgery people should learn. Neurosurgeons means it's not the only cutting. Without neurology, neurosurgery is nothing. So that's why I always tell all the neurosurgeons, you must learn good neurology. For that, you should have a good anatomical knowledge, and very, very important. Unless you have a good anatomical knowledge, you cannot become a good neurologist or a neurosurgeon. For that, nowadays, with the technology advance, the radiology, I am extremely happy that blood in the brain was talked in the morning. We were trying to learn so many things. And the clinical neurology by our Lakshmi Narasimha Garu. So seeing him itself gives a lot of pleasure for all the neuroscientists. And he is talking today, localization, wonderful experience for all the neuroscience students. So nowadays people started, the patients do come to our clinics with the two hands, big, one side, one big bunch of investigations, the other side big bunch of diagnostic case sheets. So please do not see the images in the beginning. He was insisting that we must treat the patient, not the images. So for that, you must examine properly. You should identify the 3 points he was telling. Is there any lesion? Where is the lesion? And what is the lesion? Those things must be started, and even this room, and they dissected for 1 month. So that gives a wonderful experience, even though now the lot of YouTubes have come, but physical dissection of the brain is very, very important. I think with this brief introduction from APNSI President, I wish all the success for this great conference, and I advise all the students, please do brain dissection, please read anatomy, please read the basics of radiology and learn. For all the neurosurgery postgraduates, I insist that you must learn good neurology. Thank you very much for giving me this opportunity.
Our coordinator, Dr. Biju Ravindran sir, to address the gathering.
Good morning to all the respected dignitaries on the dais and off the dais. First of all, I would like to thank the Department of Neurology, especially Dr. Sampath sir, for inviting me for this inaugural function, because he was insisting me, as I took charge of the coordination first time a week back. He said this should be the first inaugural function or any conference I should attend before anything else. He thought that I don't attend any other function, anything, and he made sure that I attend this as a first function. So Dr. Sampath, actually, sir, he has been working for more than 1.5 decade, more than a decade or so, more than that, in the field of neurology. What I have seen in him is, when others are looking for a simple neurological practice, he goes one notch above to go into epilepsy and epilepsy surgeries. He wants to go a little, one notch above all that. Second thing, what I've seen is, how do you say you're a good teacher? When your postgraduates finish your neurology post-graduation and want to come back to your department to work under you as an assistant, that marks that, he's a good teacher and they want to continue learning under him. That's one great quality I've seen in him. Very few people who finish postgraduate, they just feel, okay, I'm out of the institute. But then they have postgraduates in neurology, want to coming back to the department again to continue learning, because they know there is a chance of learning here and it is a good institute to learn, especially the Department of Neurology. Personally, what I have learned from him is, earlier when I, as an orthopedic surgeon, for me it was like, when I see a fracture, I think of treating a fracture, and I don't much used to bother about what the patient is, other thing. When the patient goes to him, he'll start from what is his name, what does he work, how many people are there, and the family members are there, what do you do, everything. So you develop an empathy towards the patient, which is not seen, very rarely seen nowadays. That is still continuing in him, and that is one quality which I have imbibed from that. So I believe this is a great platform for most of the postgraduates and the junior neurologists to learn in the Synapse Neuroclinics. I wish all the best for come and inaugural this function. Thank you very much.
Thank you so much, sir. Now I request our organizing secretary, Dr. Sampath Kumar sir, to address the gathering.
Thank you for all coming all the way from different states and gracing the academic event. I welcome heartfully from Department of Neurosciences, Narayana Medical College, and Vikramasinghe Neuro Club, Nellore, and APNSA, Andhra Pradesh, for everybody to come and grace this event. And I thank so many speakers come all the way from different states and addressing the gathering and all. So without much wasting time, so it's a time to wrap the academic program fast. So I welcome you all and be the part of the program. Thank you for everyone. Thank you.
Thank you, sir. Now I request and invite Dr. Ramanamurthy sir, organizing secretary, to speak few words.
Good morning, all of you. Sri Gurubhyo Namaha. As a secretary of APNSA, president of VS Neuro Club, and organizing chairman of this session, I welcome you all wholeheartedly. I thank the faculty for making their way with a lot of difficult and busy schedule to attend and educate the postgraduates. Only one word I can say, what I learned from my teachers, great teachers like Professor Taraknath, Professor Krishna Reddy sir, Dr. Manas Panigrahi sir, Dr. Lakshmi Narasimhan and all. Only one word I will say: PET scans, MRI scans, SPECT scans, video EEGs, X-rays, digitals, DSS. Nothing can replace beauty of clinical neurology. clinical neurology is the essence of neurosurgery and neurology. Any surgeon before operating, any physician before treating, don't miss to practice the beautiful clinical neurology. That is only one word I wanted to say. That is the only motto behind this PG Neuroclinics. I welcome you all once again for this wonderful sessions. Thank you one and all.
Kumar sir to address.
It's a very privileged and fortunate and pride time not only for me, not only for Nellore, not only for Narayana Medical College, not only for Vikram Subramanian Neuro Club, not only for APNSA. It's a pride for Indian Academy of Neurology to invite our President-elect Indian Academy of Neurology 2024, Dr. Lakshmi Narasimhan sir. A great praise of applause. Yes, sir. Please.
I request you to kindly accept the planned bouquet, sir. Thank you for coming.
So it's a great honor for me on behalf of Synapse Neuroclinics to felicitate our President-elect Indian Academy of Neurology. So to say, people asked me, what is the CV of Lakshmi Narasimhan sir? I said, one simple word. He's a best and great human being besides neurology. That's what I learned. And every Andhra and Telangana, apart from Tamil Nadu, Kerala, and of course Pan-India, he is the family man of Andhra and Telangana. Every Telugu neurologist and neurosurgeons know Dr. Lakshmi Narasimhan and they love him like anything. That is the best CV which I can always portray to Lakshmi Narasimhan sir. Thank you, sir. So it's an honor. So he has credited with so many academic research excellences with all your witness. The one which is glitters on his face is a always lovable man and great human being. Thank you, sir. Now I request our APNSA president to felicitate me.
I request organizing committee to present a small token of gratitude for Dr. Lakshmi Narasimhan sir. Thank you, sir. Thank you once again for coming to Nellore. We are really privileged to have you here in this occasion.
I thank the Almighty for this greatest honor bestowed on me. I'm emotional. But for the love of the Andhra Pradesh and Telangana neurologists, I could not have achieved this feat of becoming the president-elect of IIM. And this is the first time I'm talking in front of all of you. The first occasion as the president-elect I'm addressing in front of IIM. Hearty thanks to all of you. And more than that, my beloved friend Sampath is close to my heart, and every one of you here, Sir Ramanamurthy sir, all of you, my greatest humble pranams to all of you for honoring me this week. Thank you so much, sir. Thank you. Thank
Sir and Ramesh Naik sir to chair the session.
Professor James Jose here, I realized it will be a good learning experience.
Sir, thank you, sir. Good morning, all the delegates. I am
thankful to Sampa sir to making me a chairperson for the session, sitting with the stalwarts of neurology all over India. Thank you very much.
This is just a case presentation.
I presume it is that way. Comorbidities. He was an ex-alcoholic. He works as an audio mechanic. He repairs speakers and various phone devices relating to sound. Okay. With no known comorbidities, who is an ex-alcoholic. He works as a audio mechanic who repairs speakers and studied till 5th standard. He informed about the case, so informant is self. He presented with chief complaints of abnormal posturing of neck towards the right since 48 years, dizziness since 47 years, weakness of left upper limb since 10 years, thinning of left upper limb since 9 years, left occipitocervical headache since 7 years, and decreased left facial sensation since 5 years. So he was apparently asymptomatic till 48 years ago when he had an accidental fall of approximately 1 floor height from a tree where the right lateral abdomen and his back had impact with a boulder, where he had secondary hyperflexion or extension because it's been a long history. He doesn't remember exactly, but he some strain on the neck, post which he was asymptomatic till 4 years. So all this while he didn't attain any medical opinion. Then his mother noticed insidious in onset, gradually progressive, painless bending of neck towards the right with chin towards left, and apparent bending of spine in the region of upper back, which became static to today's level over 4 years, didn't improve or progress any further. This posturing is not episodic or painful, only limited till neck with no rhythmic movements, either in neck or arms, with no improvement with any maneuvers. Associated with difficulty in lifting left arm. So immediately after that, with this posturing, he also observed difficulty in lifting left upper arm above shoulder, but again this was painless, but denies weakness or thinning of any form, used to do all skilled and laborious works. Later, after 1 year, he experienced transient episodes of dizziness lasting for less than 10 seconds only during turns.
Change the slide.
Sir? Oh, I'm sorry. So later, after 1 year, he experienced transient episodes of dizziness lasting for less than 10 seconds maximum only during turns, either right or left, while cycling, only till duration of neck turn. So whenever there is a turn while cycling, during that duration, he has a double sensation of dizziness, but then there is no double vision, vomiting, loss of consciousness, with no other provoking factors. No similar complaints at any other occasions, or moving sides on bed, or during walking or turning sides while walking or any other positions. Only during cycling he gives such symptoms. These episodes self-subsided after 4 years without any treatment. He had difficulty in holding small wires because he is an audio mechanic. Often he uses both the hands. One he solders, other he catches small wires. So he observed he had to use nose pliers. So bigger instrument he has to use to hold small wires, but with his fingers he was unable to hold the wires. Associated with difficulty in buttoning, unbuttoning, turning page of newspaper. So he used to read newspapers with left hand. He was unable to turn. He also observed less hold in his left hand because of his professional demand. He has to lift audio amplifiers of approximate 30 to 40 kgs, which he feared might fall. Therefore, he stopped lifting the heavy ones. He couldn't lift heavy buckets for toilet or bathing, but could do the same with lesser weights. Whereas there is no difficulty in wearing shirt or combing. He states that his hand feels loose or flabby. Later, he observed insidious in onset, painless, progressive bending of left hand fingers. The inside, medial two were more bent compared to the lateral two, but the thumb was not involved. They can be corrected only with manual manipulation with the other normal right hand, which and these symptoms are continuous, they're not episodic and doesn't improve with any maneuvers or tricks. He states thinning of left arm, which he first noticed at hand, and in the same format of bending, he observed more in the medial side than lateral, which progressed till the shoulders over a period of 2 years. Since last 7 years, he has a left occipitocervical headache only on lying supine or right lateral position while sleeping, which decreases immediately after change of these postures with no increase of pain while coughing, straining, laughing, etc. Since last 5 years, he states decreased sensation on left side of the face, which he observed while shaving, but no other account of such abnormality and sensation he gives apart from the shaving what he told. And in the beard area, he states. He denies motor and sensory symptoms in right upper limb or bilateral lower limb. He denies weakness in lifting head from pillow. He is able to roll on the bed. Oh, I'm sorry. Sit without support from lying position, and there is no diurnal variation in any of the symptoms. There is no history of bowel or bladder complaints. There is no history of cotton wool sensations, Lermitis symptom, girdle sensation, difficulty to walk in dark, and there are no wash basin attacks. There is no history of spontaneous twitchings, involuntary movements, or stiffness. There is no history of attenuation of smell. There is no history of blurring of vision or diminished vision or difficulty in discriminating colors. There is no history of drooping of eyelids or double vision. History of left-sided decreased sensation on face but no motor weakness. There is no history of inability to close eyes or lips, deviation of angle of the mouth, drooling of saliva. There are no taste issues. No hearing difficulty, tinnitus, or currently vertigo has subsided, therefore no vertigo also. Complaints of hoarseness of voice, he says, since 1 year, but there is no associated jamming of words, effortful speech, and this is non-progressive, and there is no associated nasal twang or nasal regurgitation, choking episodes, or difficulty of swallowing, or slurring, rapid or slowing of speech. He is able to roll the tongue, manipulate food, and clear food from the cheeks. There is no history of swaying while walking, unsteadiness, difficulty in negotiating narrow passages, instability or unstable or moving vision. No history of postural giddiness, abnormal sweating, palpitations, bowel or bladder disturbances. There is no history of recurrent headaches, vomiting, fever or seizures. So past history, the history of fall which we have discussed at 15 years of age, 4 years prior to the symptoms. He visited local hospital once he observed the abnormal position of the neck and the back after 4 years of the fall. So he was told about some cervical spine issue, he says, and was advised some surgical management which he denied. There is recent history of right upper limb inability to lift the wrist, he says, after acute alcohol intoxication, and it improved spontaneously with physiotherapy without even visiting any doctor. He was operated for cataract 3 years ago, no other significant comorbidities or surgeries. Current functional status, he is independent in his activities or of daily living. He was born out of third-degree consanguineous parentage, normal vaginal delivery, normal birth weight, no history of NICU stay. Family history is not significant on both the maternal, paternal side or siblings or in their children. Personal history, he takes a mixed diet, his appetite is normal, good sleep is good, regular bowel and bladder habits. He was alcoholic till last 5 months ago, but recently only once he has taken last month. So he has stopped alcohol predominantly for last 5 months. There is no high risk behavior. No significant drug history apart from the SOS painkillers and all which he sparingly uses. So summarizing, 67-year-old male, ex-alcoholic, presented with complaints of insidious in onset, slowly progressive, right neck torticollis, associated with episodes of transient vertigo which lasted for 4 years and improved spontaneously, probably element type of left upper limb weakness with atrophy, left facial sensory disturbances, hoarseness of voice is the only barbar symptom which we have, so probably, and spinal deformity in the upper spine without any other cranial features, cerebellar, autonomic, cognitive or features of raised eye syndrome.
Ahmad, isn't it?
Sir.
Your name is Ahmad.
Sir?
Your name is Ahmad.
Ahmad, yes sir.
Ahmad.
Yes sir.
Ahmad. In summary, this for the trainees, no conclusion should come. Okay. Did you understand? The conclusion is that there is element type of palsy.
Okay.
This is after you discuss the history, then only you can reach that it is an element type of palsy. Like that bulbar palsy, hoarseness. They are all conclusions.
Yes, okay.
And none of your summary of history should contain any conclusions. Conclusions can be included after discussing. You can say that in summary, this patient is having an element type of palsy, etc. Here it is not the site.
Yes.
This usually happens to the residents, that they reach conclusions in
Yes.
summary of the history. There should not be any summary. Now how will you analyze and reach a conclusion from the history?
So sir, first he had this neck abnormal movement wherein the same side it was bent and the chin was towards opposite side.
You show the slides from the first, then it will be easy. I shall ask you one question.
Yes, sir.
For this patient, how many problems are there to analyze? When you present a history, the first step which you have to decide is how many problems are there to analyze. So I ask you, how many problems are there to analyze? Merit analysis.
Six.
What are they?
One is abnormal posturing of
the neck.
Transient vertigo, which is transient vertigo.
Dizziness. You said that it is dizziness.
Dizziness, yes.
Dizziness.
Which
Dizziness you have to discuss. Third.
Then weakness of left upper limb with thinning, sir.
Both comes together.
Yes.
So he has a motor symptomatology. Fourth.
Headache, sir.
Headache.
Yeah.
And finally,
decreased
facial sensory loss. You add the sixth symptom also. What is that sixth symptom? Hoarseness of voice.
Yes.
So first you have to decide what are the symptoms which require analysis. So now you discuss showing the slide, then it will be easier.
Whenever you present, your analysis of the symptomatology should ultimately culminate in one what you call conclusion, whether it is an encephalopathy, a myelopathy, a myeloradiculopathy, or a radiculopathy, neuropathy. Okay, you should make an attempt to go that way.
Yes. In the end,
it appears slightly what you call haphazard, confused.
After summary, I have some localized it towards it.
So you have mentioned about that you should describe.
Actually, I have mentioned. Sir.
What is your conclusion, analysis of this torticollis?
Sir, because it is so, sir. Usually, dystonias are upon attempted movement.
So your analysis should be like this. There is a abnormal posturing, which I will call it as a local condition, which may be due to a trauma, which may be a birth trauma producing a muscle problem, contracture, or it could be something in the vertebra, a vertebral pathology. They are all characterized as a local problem.
Yes.
Thirdly, it could be a ophthalmological problem.
Yes,
it's a compensatory.
Yes.
A compensatory phenomenon.
Superior.
So that sort of broad classification should be there to analyze each symptom. And then after taking that, you have to substantiate that it is not dystonia because
one it is not movement induced, sir. It is continuous. It is not episodic.
It is not episodic.
It is not induced with any movement. And there are no sensory tricks or maneuvers improving it.
You are not audible.
There are no maneuvers or tricks which is improving it, sir.
Is it compensatory for a eye movement problem producing
Sir?
Is it a compensatory torticollis as seen in a fourth nerve palsy or in a sixth nerve palsy?
Sir, in the further history, we have ruled out, sir, that eye-related he has no problems.
Exactly.
Yes, sir.
So that history of ophthalmology problem, you may even bring to this history.
Okay, sir.
So you think that this torticollis is due to?
Local musculoskeletal problem.
So local
cervical
musculoskeletal.
trauma. Yes.
That is what is meant by analysis. This is the way in which you have to analyze.
Yes.
You take a symptom, and you say what are the possible issues which can produce this problem, and each problem is excluded because of such and such problem, and finally my conclusion is that this is a local problem. That is what is meant by analysis.
Yes, sir.
Anything to add, sir? No. So that is the first symptom. First symptom we analyzed it in such a way that even though so many other problems can be produced, it's due to a local problem, and it is induced by a fault.
Trauma.
Isn't it? So what is the likely local problem?
Sir, at the cervical vertebral injuries, sir.
Some vertebral. That's what we can say, that it's induced by a fault. If that history is correct, it is a cervical spinal injury, which has produced the fixed deformity.
Yes, sir.
That should be our analysis.
Yes.
Now go to the second symptom.
So second,
Just a moment. If it has been produced by a cervical spine injury, it would have caused torticollis. Torticollis would have been not the presenting feature, number one. If there is a paraspinal muscle dysfunction, which has arisen how many months or years after the fall?
4 years.
4 years. So, how much do you think the fall could have been responsible for this torticollis? Do you link both, or is it appropriate to link both or not?
So there are some causes wherein post-trauma delayed torticollis can arise. Sir.
Delayed torticollis.
Yes, there is both acute and delayed, sir.
There's two faults.
4 years is too long a period for torticollis to...
Sir, one factor here is, sir, this is 50 years old history, sir. So he has some confusion with his own history also. And that time he was just 15 years old, sir. So his parents...
If it is traumatic, which muscle involvement do you think could have produced torticollis?
Sir, such a movement wherein there is turning towards the same side and tilting towards the opposite side will be produced by ipsilateral sternocleidomastoid.
Sternocleidomastoid, right. So, do you give credence to sternocleidomastoid dysfunction or vertebral body kyphoscoliotic changes that has produced this torticollis?
Because it has been so slow, sir, probably that trauma or some minor fractures must have set in that way, and over time the muscle has adapted, I feel, sir. So more towards vertebrae rather than muscle problems.
No. 4 years after the trauma, patient developed progressive torticollis, or is it acute?
No, sir.
Progressive.
Progressive.
What possibilities you can consider in this situation?
Sir, another reason could be local radiculopathies or...
4 years afterwards, local radiculopathy causing torticollis. You agree with him, sir?
Exactly. That problem, I agree with sir, because the bony abnormality, that usually won't become progressive.
Sir, then finally it can be a syrinx which is gradually affecting it can be a intramedullary pathology, sir, like post-traumatic.
At that time, what intramedullary pathology will produce the torticollis?
Suppose paraspinal muscles, if it is affecting
what disease will produce paraspinal spasm? So that sort of thinking is, I don't agree. The problem is it could be following a fall, it could be very well be a local problem, could be a vertebral problem. The question remains why it should progress. The torticollis should have remained like that, either fixed or corrected after a trauma. So it is getting progressively worsened.
Imbalance in muscles, sir, between both the sides.
So one possibility, as sir has said, is a progressive muscle problem may be adding up, which is producing a improper balance of the neck muscle producing. Anyhow, it is a local problem. We are sure that it's a local problem, either a vertebral or a progressive muscular problem.
Yes,
sir. Is what you meant. Anything?
Could you think of any parapharyngeal pathology? See, it being a torticollis, laterocollis, like that. Could you think of any that's such time duration, 4 years of getting? So you being in countries like India, what is the first differential diagnosis you have to think? Any parapharyngeal pathology?
Abscess, sir.
No, abscess is not that much chronic. So any parapharyngeal lymph nodes or any pathology or any tuberculosis you have to rule out. That's such long history of 4 years that you should keep in mind.
What should be the second symptom which you will analyze? See, in analysis of symptom, I shall tell you, see, what I advise is not go for piecemeal analysis. Piecemeal analysis means that a patient has got a fall. At that time, after some time, he developed a weakness of one upper limb. Then he developed a facial sensory. Then he developed a weakness of left lower limb. Then he developed a weakness of the other upper limb. This sort of piecemeal presentation will be there for the patient. A candidate can take each symptom at that moment and then go for analysis of that symptom and localization. But that become a very haphazard way of analysis. I will say that if multiple areas affected in a chronological manner by a disease, that all symptomatology should be taken together and you should analyze. That's what I was associated with the difficulty in lifting arm above shoulder, but denies weakness of the neck. Did you understand? So, when a patient has got a motor symptomatology, which affects the multiple areas in a chronological way, not simultaneously, I will advise that you take them together and reach a conclusion and localize that symptom. Like that, the sensory symptom also. That is easier for analyzing and localizing rather than taking piecemeal. So now, tell me what is the second symptom which you are going to analyze in this case?
Second, we'll see about this transient dizziness, sir.
Transient giddiness.
Yes.
Transient giddiness.
Yes, sir.
What do you think?
Sir,
what is the description? Show the description also. Next slide.
So, later, after 1 year, he had these episodes, sir. So, whenever he was turning sides on a road, on his bicycle, he used to feel dizzy during that much period of turning. Later, those episodes would subside. There was no other provoking factors apart from that, like change of postures.
Exactly, we understood. So what do you think the cause for this dizziness?
Sir, because it has subsided spontaneously, most likely first cause could be a traumatic positional vertigo, sir.
Very well. He has a dizzy feeling and lasting for a few seconds without any other associated symptoms, and it occurs during the neck turn only till duration of the neck turn. So when he turns his neck, he developed a dizziness. So this could be very well be a labyrinthine dysfunction, what you call as a positional vertigo.
Yes.
Positional vertigo.
Yes.
That's very simple line.
Yes.
What dangerous thing will you consider in a patient with a fall, rare neck, torticollis, and a giddiness?
Vertebrobasilar insufficiency.
That also you have to consider.
Yes, sir.
Vertebro-labyrinthine problem can produce this one, and a vertebro-basilar insufficiency which has subsided spontaneously.
Yes.
Must also be considered.
Yes.
Can I? When you're discussing a long case, you should follow some rules. at the end of the presentation, you should summarize. You have summarized. You should analyze each and every symptom. What is the syndromic diagnosis? What is the anatomical substrate responsible for these symptomatology?
After summary.
Third is, what is the likely pathology? The last one is etiology. Still last one is prognosis.
Yes.
So, it's a case of chronic torticollis.
Yes.
You have not mentioned whether this torticollis was there in the sleep or not. That can differentiate whether it is a movement disorder or not. Okay? It is a sustained torticollis. That means it's not a movement disorder.
Yes.
And what is the anatomical substrate for this torticollis? Is the weakness of sternomastoid, which is asymmetrical. See, he's turning the chin to the opposite.
Yes.
And there is deviation of the head to the right side.
Yes.
Chin is to the left side. Hood side is weak. All these things are, otherwise, what is the use of these clinics?
Yes.
You should analyze each and take up each symptom, reasonable anatomical substrate, reasonable pathology, then reasonable etiology.
Yes.
Not directly going into the etiology, what is a torticollis, sustained, present even in sleep.
Yes.
That means it is a mechanical problem.
Yes.
And you are very clear that, we are all clear that there is weakness of sternomastoid on one side, probably on left side.
Yes.
Is it not?
Yes. Yes, sir.
When the left sternomastoid is weak only, right is overacting.
Yes, sir.
Causing the chin to opposite.
Yes.
So what could be the cause for the weakness of left sternomastoid? All these things I have to mention. Otherwise, just volatile. Understood?
Yes.
Thank you.
So that is analysis of the giddiness. So we don't know whether it's a very significant symptom or not, or it could indicate a very serious problem.
Yes.
Now go to the next thing which require an analysis.
So later he had
one minute. So your localization of giddiness is, so you have ruled out inner ear pathology. So you are telling episodic. I say it's a Meniere's. How do you differentiate that?
Meniere's will have associated sensory neural hearing loss, and those symptoms also.
Say any hearing loss associated with that, you have any tinnitus. You have
Tinnitus.
So it will last for hours, not seconds. That you used to know. Second thing, so he is complaining of giddiness only on turning the head to one sideways, not in the bed like that. So turning right or left. Is there any associated arm claudication? While doing that, is he getting anything? So it seems to be vertebrobasilar. You have to rule out in the history whether any subclavian steel syndrome like thing. So any arm claudication, that history you should get in here, because you are excluding that postural variation. BPPV, it was ruled out. We don't know postural semicircular canal, we don't, or horizontal, anything like that. You have ruled that. And then second thing, you are thinking of vertebrobasilar means you have to rule of any arm claudication while doing or placing any objects over the, that history you have not asked here, and you should ask that.
Okay.
So now go to the next.
So next he has difficulty in fine movements, like skillful movements. So
Next symptom is coming under what category? Motor symptomatology.
Yes, sir.
That's what I was saying, that rather than taking each segment together, you group them and go for analysis, then it is easier and time saving. So the next symptomatology which you want to analyze is the motor symptomatology.
Yes, sir.
The question is, you have to answer is, what are the motor symptomatology which this patient is having? What are the motor symptomatology? Where are the muscles affected? What are the muscles or segments affected? And if it is weakness, what is the type of weakness which patient is having?
Yes.
Proceed.
So it started distally, sir.
So which are the segments? Where does it started first?
Segments is
segment?
C7
Need not segment. Segment I mean that proximal upper arm, distal upper arm, like that. It's not C7, C6.
Okay. Distal.
Distal, like
So
that.
it started distal to proximally it has begun, sir.
Affected.
Distal to proximal.
So he has weakness of hands.
Yes, sir.
Which
Asymmetric.
hand? Which hand?
Left hand, sir.
Left hand. Then
It is limited in history, just limited to left hand.
any weakness anywhere else?
And later to the
Later,
proximally also, sir, in the
proximal
same
also.
hand.
So it started in the distal, then it affects the proximal. Which arm?
Left arm.
Left arm. What is the situation of right arm?
Right arm, till history it is normal, sir.
He
No
has
symptoms.
no problem. Any problem with the lower limb?
No, sir.
No problem.
Yes,
So
sir.
what you have to do is, he has a weakness or he has a motor problem which affects the left upper limb, initially distally and then proximally.
Yes, sir.
And then you have to analyze it.
Yes, sir.
Proceed.
So because there is associated thinning.
So elaborate that weakness.
So weakness, sir, fine movements when he was doing holding wires, turning pages, buttoning, unbuttoning.
Here you can use this slide and then you can analyze.
Yes, sir. So he had difficulty in holding small wires solely with fingers. Rather, he has to use nose pliers. So the gross movement was normal, sir. But the muscle, small muscle, once he want to move.
He has problem with the hand.
Yes, sir.
Isn't it? That
Yes,
is
sir.
one area where weakness is there. Which hand muscles are affected? That is the question.
Small muscles of the hand, sir.
Why did you say it is small muscles?
Because fine movement he has weakness, sir. The long movement.
Which movements? Read that one. He had
like holding small wires, sir. Thin wires,
Ah.
buttoning, unbuttoning, and turning pages of newspapers, sir.
newspaper.
Hmm.
Associated with the difficulty in buttoning,
unbuttoning of shirt,
unbuttoning, turning pages of the newspaper with the left hand.
Yes.
Which is the muscle most important for buttoning and unbuttoning?
Flexor digitorum profundus, sir. And abduction of the shoulders, sir. Lifting hand above
Usually,
shoulders.
by conventions, shoulder abduction.
Combing, wearing
Shoulder
a shirt.
abduction.
Yes, sir.
Is there any symptoms to suggest a abduction weakness?
He's able to wear his shirt, sir. But there is difficulty, like he has to manipulate it, but overall he is able to wear it, but there is difficulty
Is he has
in
difficulty in lifting up above the shoulder?
Sir?
Is he has difficulty in lifting the hand above the shoulder?
Yes, sir, he has.
For what?
Above the shoulders. Above shoulders, sir.
He has difficulty.
Yes, sir.
Okay, so what you have to think is when you analyze these things, hand muscle you have to see whether there is weakness. Then you have to see forearm muscles. Forearm muscle mainly holding things. Then you should see whether he has difficulty in flexing and extending. Then you have to see whether patient has got difficulty in lifting up to 90 degrees. For shutting, buttoning and unbuttoning need not elevate.
Yes.
But for eating, he has to elevate up to 90.
Yes.
If he has to take something above the shoulder, he has to again raise above that.
Yes.
All indicate different muscles. Up to 90, it is supraspinatus and
Trapezius, sir.
deltoid.
Deltoid, yes.
After 90 degree, it is
Trapezius.
trapezius and serratus.
Sir.
That is the way in which you have to take the history of weakness. Leave it. We are running out of time, so we will say he has weakness of left upper limb, proximal as well as distal.
Yes, sir.
Then what will be the next step?
Associated any sensory symptoms?
Is it a LMN
or
UMN?
Yes.
So once you say that it is a weakness, then you have to say whether it is a LMN or UMN. What is your conclusion?
He states looseness or flabbiness, he says, associated.
Then, what is the strong point to suggest it's whether it's a LMN or UMN?
Progression. Sir,
Simple
it is a
points.
problem of movement, sir, rather than
No,
muscle.
no, no. They are all very basically, how will you differentiate between an element and human? Whether there is any wasting. Has he got wasting?
Yes, sir.
He has. Isn't it? He has wasting.
Yes.
He has?
Wasting is there, sir.
He
Yes.
has wasting and he has flabbiness. So it is a
Element problem.
like to be element.
Yes.
That should be your next conclusion in that.
Yes.
In that symptomatology.
So first you have to mention about you have not told about the actions which the small muscles which there was a problem with, that you have to see. And second thing is, so you mentioned only the actions of that long flexors of forearm and that turning of pages. What do you want to convey?
When lumbricals.
Not lumbrical. See, turning of pages with the left hand, not able to. Which muscles they are helpful for turning?
Along with long flexors, also adductor of the thumb, lumbricals.
See, pronator. So pronator supination. So pronator teres quadratus. So you have mentioned only the muscles of the forearm. You have not, in the history, you have not mentioned about the usage of the small muscles of the hand, as Sir said, told. So proximal, still more you have to elaborate. And then associate not only wasting, you have to talk about the fasciculations, any fasciculations in the involved limb. You have to say, you have to convey whether any anterior horn disease is there. You have to rule out that. Okay?
So move to the next symptom.
Then there is bending of his fingers, he told, sir, crudely in his language, which was more medial.
What does this symptom indicate?
Clawing, sir.
Clawing.
Yeah.
Are you sure? Need not, because it usually happens. If a person is having a finger drop, when you look from here, it is finger drop. When you look from here, it is bending of fingers, isn't it? Patient is having finger drop. This hand is like that. If you are seeing from dorsum, it is finger drop. But if you are seeing from this side, it is a bending of fingers. So a bending of clawing. Time and again it happens that patient will come to you and say that my two fingers are now, is the C fiber different? The concept of touch has changed a lot to the extent that a Nobel Prize has gone recent years to that one. And you should remember that there is a type of touch which is called C fiber touch. It is the touch which is seen with the caresses. When you slowly touch the hair, you get a special sensation. These are carried by the C fiber touch. When you shave, the C fiber touch are stimulated and it is decreased. Now you can say what?
చల్లగా నీళ్ళు వేడి నీళ్ళతో ముఖం కడిసినప్పుడు తెలుస్తుందా? రెండు వైపు ఒకటి తెలుస్తుందా? అది ఎడం వైపు కుడి వైపు తేడా ఏం లేదా?
Okay. Is okay.
Yes, sir. He says.
See, our concept of a small fiber, you should remember that small fiber is there for pain, small fiber is there for warmth, small fiber is there for cold, small fiber is there for proprioception. Proprioception, C fibers.
Yes, sir.
Its lowest is the one which produces Charcot joints.
Yes.
Similarly, C fiber touch is there, which is the fiber for emotions and caresses. And small fibers are there for itch also. See, some of the patients with neuromyelitis optica or herpes zoster, they will come and say that itching. That's also again a small fiber symptom. So it indicates that the small fiber system is involved, which is evidenced by the absence of sensation when he is doing the shaving. Will you agree with me?
No, sir.
Will you agree with me?
No, sir.
Why?
I had put it at nuclear level, sir. High, sir.
I didn't go to any nuclear or, see, you have to, this is, he is a bit more basic. What you have to see is our sensations you have to consider as two systems. Large fiber system and small fiber system. It could be either peripheral or central. If it is spinal cord, it could be substantia gelatinosa. If it is still in the spinal cord, it could be the crossing fiber. And it is as a tract, it is a spinothalamic tract. That is what is meant by small fiber system. Okay. It's not small fiber neuropathy or anything. Like that, there is a large fiber system. Large fiber system means that the large fibers in the peripheral nerve, the fibers which are not crossing but ascending as the posterior column, and in the medulla to act as a medial lemniscus. All these are large fiber system. What I have said is not large fiber, small fiber, neuropathy here. Yes. I said it is a small fiber system. You should differentiate what is meant by small fiber system and large fiber system. They are one and same, producing all the same problem. In a neuromyelitis optica, you get itching because the small fiber system tract is affected. In a herpes zoster, you will get itching because the small fiber system, the peripheral nerve is affected. Here what I have said is large fiber system, either in the nerve or in the nucleus or the spinothalamic system, anywhere.
Yes.
Now will you agree with me?
Yes.
Okay.
Musculoskeletal.
Muscle problem, local torticollis, muscle may be progressively affected. Your giddiness?
Either benign or vertebrobasilar insufficiency.
No, we don't know.
We don't.
Could be considered vertebrobasilar problem. Third problem?
Weakness with atrophy.
Weakness. What sort of weakness?
Weakness with atrophy without sensory.
Element type of weakness. Fifth symptom is his hoarseness, indicate a cranial nerve or cranial nuclear involvement.
Yes, sir.
Sixth symptom is
decreased sensation on the face.
Sensations lost from the face.
Yes.
C fiber touch system is involved. So taking together these problems, now you have to go to the. It need not be very prominent.
Atrophy is not a prominent.
Atrophy is not the problem. So what is the remaining site?
Anterior horn cell.
Anterior horn cell disease. Which anterior horn cell disease?
So it has started
distal. So where you have to take other symptomatology. Anterior horn cell could be a degeneration of anterior horn cell, a secondary anterior horn cell disease. Isn't it? It could be a secondary anterior horn cell disease or a primary anterior horn cell disease. And to categorize that, we have to go for the other symptomatology. What is the next symptomatology which will help us to localize etiologically and other factors?
Absence of sensory symptoms.
He has a sensory symptom. Where?
In the hands. On the face he has.
Face he has a sensory symptom. Can in a primary problem, primary degeneration of the anterior horn cell, like a segmental anterior horn cell disease or a Hirayama disease.
No, sir.
Will they develop this facial problem?
No, sir.
No. So this is a problem which has affected the sensory system also.
Yes.
So it is not primary.
Yes.
Isn't it? So it is a secondary.
Yes.
Likely to be a secondary anterior horn cell disease. Any other symptoms which will help us to localize?
Hoarseness.
25 minutes left with discussions.
How many?
25 minutes, sir.
For examination and discussion, isn't it?
Yes, sir.
For everything. So we have to cut short. So hoarseness indicate what? We have already discussed.
Yes, sir.
So all together we have a localization. Anterior horn cell is where?
Anterior.
In the spinal cord. Facial sensory is where?
High cervical.
High cervical. Hoarseness is for where?
Medulla.
Medulla. So there is a lesion which extends from the cervical cord. Lower portion is C8.
C8T1, sir.
Up to lower medulla.
Yes.
There is a lesion.
Yes, sir.
Because of these small points. What could be the etiology?
Given the trauma history, sir. Traumatic syrinx.
Is it sufficient? Sufficient strong trauma, or is a minor trauma?
Significance, one floor.
Significant. So it could be a traumatic. Or traumatic. What is the problem with the trauma? Immediately patient won't have any problem. Most of the traumatic problems progress after initial problem, then they progress.
Yes.
So unlikely to be a traumatic problem, it could be a primary problem.
Intramedullary tumors.
Intramedullary problem which has happened.
Slow growing tumors.
That is my or your analysis, sir.
As far as trauma is concerned, 4 years after the trauma, the patient has developed symptoms. You can link it, and it is more likely that it is not because of trauma. So you will have to, present it in two contexts. One related to trauma, two unrelated to trauma. And the symptomatology being unrelated to trauma is more appropriate than it is related to trauma. But however, in the exam, since trauma has been there, the possibility of the lesion because of trauma occurring after so many years means post-traumatic syrinx altogether can't be totally denied. So somewhere down in the list you must have to add, but it has to be presented as a primary intramedullary lesion. What's the problem?
Okay.
Isn't it so?
So could it be CV junction anomaly acquired? So what are the points in favor of you that, and what are the points against that?
CV junction anomalies.
So all the lower cranial nerve, almost all.
Valsalva headaches we didn't see.
It's not a pure motor, as you said. Some sensory component is there, loss of sensation over the left. Then could it be a CV junction anomaly, acquired cause, not congenital?
Restriction of neck movements. Apart from this positioning, he didn't give an estimate. CVJ anomalies will have significant restricted movement. Restriction of neck movement will be also one prominent symptom in CVJ anomalies.
So nystagmus, so downbeat nystagmus,
Lower
and then
cerebellar
lower
symptom.
cranial nerve palsies.
Yes.
And then, so you have to, so what are the positive towards that, and what are the negative towards that? Fastly, and so time is up, 20 minutes.
High cervical lesions. What other features you're asking, sir?
One small point, you got the post-traumatic syrinx. Generally, it's very rare. Post-traumatic syrinx will be preceded by some sort of spinal cord injury from which myelomalacia, then syrinx cavity appears. So it has to be preceded by a fixed deficit. From there, it will progress. The so-called post-traumatic syrinx is what I want to add. Okay. In my 23 years of career, I have only seen 2 cases. Is not such kind.
Exactly what I was saying. If it's a post-traumatic problem, at the time of trauma, there should have been a.
Yes.
Oh.
Okay.
So, any opinion from the audience?
So change your priorities. Okay, benign intramedullary lesion. Traumatic syrinx comes somewhere down below.
Sure.
Down below. All right.
Syrinx. Okay. Yeah.
Proceed. We have 20 minutes.
So on general examination, positive findings, what were there is kyphoscoliosis at thoracic level towards left, and there's this torticollis, neck, height to neck ratio.
What are the common conditions which produce scoliosis in neurology?
Look, acute anterior horn cell disease like polio, sir.
Polio.
Yes, sir.
Polio. Second?
Trauma.
Trauma usually won't produce scoliosis.
Sir, congenital myopathy, sir, wherein there is imbalance.
Myopathy very rarely. And one is, the commonest is?
Anterior horn cell disease.
No, syringomelia.
Syrinx.
The surgeons, neurosurgeons are always worried about the scoliosis. They will see the scoliosis angle less than 20, more than 20, etc. So there is a common condition.
Paraspinal muscles will be involved. Yes, sir.
Exactly.
Yes.
What is the second condition? Polio.
Yes.
What is the third condition? Hereditary ataxias. Hereditary ataxias. Fourth is neurofibromatosis.
Yes.
So whenever you see a scoliosis, immediately you have to think in neurology, are we dealing with any of these conditions?
Okay.
Proceed.
So height to neck ratio is increased.
Any fasciculations are there?
Piece of general examination.
You have said about the right upper limb wrist drop since 1 month back in the history, and
Yeah.
it improved spontaneously. Do you
Yes.
think is it a part of the disease which has started, or do you want to separate it and
No,
tell?
I feel that is a separate problem, sir.
Sir, that the faculty can add anything like
It need not be. In the
pressure palsy,
not pressure palsy, you know that a syringe, the pressure inside the syringe, am I correct? He will be the correct person.
The clinching point for syringe is change in sensory level with the Valsalva position. Same thing happens in the motor. Suddenly presenting with a wrist drop and spontaneously improving. That means syringe cuts through the tissues of the cord, right? With the Valsalva maneuver. Just you have to inquire whether the patient had Valsalva prior to the fresh neurological. That's the diagnostic feature of syringe. If it has a fresh neurological deficits after the Valsalva, that almost diagnose written on the face of the patient.
Sir,
Is it not, sir?
classically he says he slept on his hand that much level.
Okay, proceed.
Yes. Then low hairline, claw hand on the left side, sir, which is complaint. Vitals data is normal.
Yes, agreed.
Yes. Neurological examination, speech. There's hypophonic speech with nasal twang, sir.
Not audible. Doubt.
In higher mental functions, he is conscious, coherent, oriented, right-handed person. Speech is hypophonic with nasal twang, sir.
Nasal
kind of.
twang.
Yes, sir. Flaccid dysarthria.
Just paper I'm
మీ పేరు ఏం పేరు అండి గట్టిగా చెప్పండి.
సాంబమూర్తి 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 సాంబమూర్తి
సాంబమూర్తి
కాళశ్రీ కాళశ్రీ.
Agree that there is definitely portions of voice. Nasal twang, you have to check different words in Telugu. Proceed. Shall we examine him when he is present? Shall we examine him? Sit down, sit down. You present.
Sir, positive finding should I say, sir?
Positive.
In cranial nerve examination, pain is decreased in the V3 area, sir. The pain is decreased in the...
No. You said, what is the cranial nerve examination findings?
Olfactory, optic, 3, 4, 6 are normal, sir.
Normal.
Coming to the fifth nerve. In pain sensation is decreased on the V3 area, sir, mandibular area.
Mandibular area.
Yes, sir.
Okay, then.
But jaw jerk is brisk, sir. Jaw jerk has come brisk, sir.
Brisk.
Yeah.
Okay. Then, how is the palate?
Palate moving equally, sir. Uvula mild deviated towards right, sir. But the movement is equal. Movement is equal, sir.
Equal.
But reflex is lost. Gag is lost.
Gag is lost. Tongue?
Tongue, tone and power, bulk is normal, but fasciculations.
How is the 11th?
Sir, tongue fasciculations are there.
Fasciculations are there. Then how is the neck muscles?
Flexor weakness is there, sir.
Flexor weakness.
Yes.
ഒരു മിനിറ്റ് ഞാൻ വെരിഫൈ ചെയ്തോട്ടെ സാറേ. Come on. Agreed that there are certain fasciculations are there. Give me a knee hammer.
కొంచెం నోట్ తీరండి కొంచెం కొంచెం ఎస్ ఎస్ ఉంది సార్
హ్యాండ్ ఎగ్జామినేషన్
Has he got hornets?
No, sir, no hornet, sir.
It's not positive.
No, sir.
His muscles are mechanically contracted. Jaw jerk is not present. Has he got a downbeat nystagmus?
No nystagmus, sir.
Downbeat? How will you check downbeat nystagmus?
Well,
Which position?
looking up.
No. Down? You should be down, isn't it? Examiner won't be happy with down alone. You have to see down and out. Down and out is the position for demonstrating.
What is that sign called?
Laroff sign.
To which side he has got torticollis or head tilt?
Right side, sir. Tilt is on right.
Is it painful or painless?
Painless, sir.
Is it correctable?
Yes, sir.
He is coming to that only. He is now in this area. So I agree with your tongue fasciculation. I have no disagreement of the facial problem. Then he has no downbeat nystagmus. I disagree with your exaggerated jaw jerk.
Okay.
And other things are okay, isn't it? You said that this is not correctable. This is correctable, isn't it?
No, why did...
What is the difference in hand between these two? This is a wasted hand.
Yes,
but
sir.
what is the difference? Which muscle is bulky? Which hand is bulky?
This is bulky.
No, but you see the hand. Which is bulkier? Which is bulkier? This is bulkier.
Yes.
This is bulkier. It is actually edematous. This hand is what is called man and succulent, juicy hand. If you see a juicy hand and exclude complex regional pain syndrome, you can stop the examination and make a diagnosis of syringomelia because of its autonomic involvement. Once you see man and succulent, stop the examination.
Man?
Man, man in grief like man. Man and succulent. Succulent means juicy. So here's the typical man and succulent hand.
Okay.
See, you can see that it is very edematous.
Yes, sir.
Juicy. Feel that.
Yes.
Just feel that. See, feel this one. Very juicy hand.
Yes.
So actually, if I am in the clinic, I will stop examining here because of this peculiar hand which is seen, visible. See, it's different. Parietal is not edematous. It's an atrophic hypotonic hands. So spinomotor examination finish in 5 minutes.
So, sir, small muscle atrophy, sir. All the
Small
muscles
muscles
of
are
the
there.
small muscles are weak, sir.
There is a clawing which involves mainly the lateral
Yes.
hand. Lateral
Yes.
hand. Then there is a correct.
No, he has psoriasis, sir.
Psoriasis.
He has vitiligo and psoriasis both. This
Okay, psoriasis, but such a focal lesion.
No, he had this complete hand, sir. He showed those amolifin creams and all also, which has improved.
But nails are not involved here.
Leave it. We will
Pits
say
and all.
maybe a
Yes.
total. We
Even-
expect ulcers and at the tip.
Even in the forearm, there is asymmetric atrophy, sir. And it is upper limb also, sir.
Any
There-
fasciculations?
No fasc.
Your mic.
So, even in the forearm, there is asymmetric atrophy, sir. Medial border is more
Agreed,
atrophic.
agreed.
Then in the
Fasciculations?
no fasciculation,
No
sir.
fasciculation.
In the shoulder girdle, there is atrophy in the infraclavicular part, suprascapular part. Chukkat is. So even the shoulder girdle, infraclavicular and supraspinal scapular areas are
Coming
atrophic,
to
sir.
power. Tone.
Tone is very flabby, sir.
Very flabby,
Hypotonia.
upper limb.
Upper limb.
Power.
Power, proximally, it is relatively but abductor, sir. Shoulder abductor are more weaker, sir.
How many minutes?
10 minutes more, sir.
10 minutes. Sufficient. I will give you 10 minutes from my time. No problem. So, idonnu pokki. Just ask him to lift.
Net and
Keep it. Keep it. But ingottu vokkan parne. See the difference?
Yes.
Poka. Up. Have you seen the hand? What does it mean? See, he is able to lift up to
90 degrees. Sir.
almost 90 degrees.
Yes, sir.
He is not able to elevate it above that.
Yes, sir.
like this one, it indicates that he has either weakness of trapezius or serratus anterior.
Yes.
Serratus anterior.
Yes.
And you missed some more. Is there polyminiomyoclonus?
Yes, sir. Yes.
Okay. So how is the reflexes? See, these sort of signs you should elicit proximal.
Sir, upper limb starting from trapezius, scapulohumeral.
How is the
absent,
trapezius?
sir? Absent, sir. trapezius.
Reflexes are absent.
Absent, yes. Sir.
Trapezius is absent, biceps.
Biceps, triceps, supinator, all are
How is the lower limb reflexes?
brisk, sir.
Brisk reflex.
Yes, sir.
What is inverted supinator jerk?
Inverted supinator means instead of supination there will be flexion of fingers, sir.
Okay.
With absent biceps, sir.
Who invented? What will happen to triceps?
Triceps will also be exaggerated, sir.
It?
Exaggerated.
Inverted supinator jerk localizes your lesion to?
C6, sir.
C6 what?
C6 spine.
C6, sir. No.
Who described this reflex?
No.
It is inverted supinator jerk localizes to
C6 cord. Roots.
which somatome. Somatome involvement.
Your answer should be.
Yeah.
Your answer should be. This always happens in the examination. What is inverted supinator jerk? Inverted supinator jerk means there is absent or sluggish supinator jerk in presence of a exaggerated finger flexion reflex. This indicates a spinal cord lesion. Spinal cord lesion level C5, C6. C5, C6. This is because the rule is that in a spinal cord lesion, at the level there will be a LMN lesion, below the level there is a UMN lesion. C5 is for brachioradialis, C5, C6 is LMN. That is why the reflex is absent. C finger flexion is subsided by C8 segment for which it is UMN. That is why it is exaggerated. It may be or may not be associated with exaggerated tricep jerk also. That should be the answer. Like that for clawing. When there is a clawing, the question will be what is clawing? The Spsr answer will come. You should say that clawing is a deformity of hand where there is hyperextension at metacarpophalangeal joint and flexion at interphalangeal joint. Indicate weakness of the lumbricals, weakness of the lumbricals which usually extend this joint. In presence of a relatively preserved long extensors, which is the cause of hyperextension, and a relatively preserved long flexors of the forearm, which is the cause of the flexion. These are the two questions I am actually afraid of asking these questions to DM candidate because I never get a correct answer. So learn this one and answer correctly because they are all very localizing signs. Here there is, I agree that there is clawing. So all his reflexes are sluggish. Elicit the knee jerk. Just show how is the knee jerk.
Have you examined for the trapezius?
Oh, absent.
Absent. This is just elicitable or brisk?
Brisk. 3
or
plus.
exaggerated? I will go for an exaggerated.
Yes, sir.
How is the power in the lower limb?
Normal, sir. Power.
Normal power.
Yes, sir.
How is his
any difficulty in walking? In the history?
Spastic gait, sir. But in history, no difficulty, sir.
How is his gait?
Gait, spastic gait, sir.
Not ask him to.
And the hands are flaps.
We call it as spastic gait.
Mild I have written, sir.
What is the striking feature? You just walk. I'll say that bit unsteady when he is walking.
And associated movements of the hands.
See, when a patient is having spasticity, it will come forward and medially. It's not. The question is why there is circumduction
So
in a spastic
in
case.
legs, in UMN lesion, there will be weakness of anti-gravity muscles, which are flexors, hip flexor and knee flexors. So that's why the leg will go into a extended and abducted position.
Everything is
Those are
sit down. Okay.
So have you looked for any ring of scapula? Here there is bulging of the.
Because of the scoliosis, he is having a bulge.
Yes.
I test for the. ఇలా వచ్చి ఇలా పెట్టండి.
yes, sir.
Remember dates in the upper limb.
Yes, sir.
Deltoid, which is an abductor, triceps, extensors of the wrist, and
Because of the
extensors
scoliosis.
and supinator.
Yes, sir.
When they get weakened, opposite muscles take over. If deltoid gets affected, they cannot abduct it. It will be abducted. If triceps gets affected, they cannot extend it. It will flex. If the extensors of the wrist and fingers get affected, they will be wrist flexed. And if supinator gets affected, it is pronated.
Yes.
Likewise, in lower limb, it is HD. High density muscle. Remember hamstrings, hip flexors and dorsiflexors. So when the hamstrings get affected, they cannot flex, it will be extended. When hip flexors get affected, they cannot flex. When dorsiflexors get affected,
Plantar.
so this is the classic gait. So since there's a foot drop, to clear off the ground, they have to encircle and walk. So because it is for DATES muscles in the upper limbs and HT muscles in the lower limb.
So after
The other muscles take over.
After the examination, are you more wiser?
Yes, sir. Obviously.
In what way?
Once the element type of
We
weakness is
verified
confirmed.
and confined that it's element.
Yes, sir.
Then there
And-
is a man in succulent day.
Yes, sir. So autonomic.
And not only areflexia on the one hand, the other upper limb is also areflexic.
Yes, sir.
And you found that the lower limb reflexes are exaggerated,
Yes, sir.
indicating probably an mild involvement of the pyramidal tract.
Yes.
All other things we have already
Discuss. Yes.
So do you want to change the extent of involvement or the etiological diagnosis?
No, sir. There's no change.
What is the extent of involvement in this case?
So CAT1. till
Lower
T1.
down,
Lower
it is
down
up to
it's not-
T1.
T1, sir.
Up.
Lower medulla, sir.
Lower medulla.
Yes.
Lower medulla. What is the evidence of involvement of lower medulla?
This absence of gag and tongue fasciculations.
Tongue fasciculations and
And
hoarseness of
fish-
voice.
hoarseness.
Hoarseness of voice.
Yes, sir.
He has facial involvement, is
Facial.
sensory.
Yes, sir.
Which sensation is lost?
Pain, sir.
Pain is lost.
Yes.
Indicate what?
Spine.
Need it be due to a medullary lesion?
Yes, sir. Even in medulla,
Yes, saying that.
again it can be spinothalamic tracts related to pain of fifth nerve. sir.
No. See, it is from the
Spinal
mandibular
nucleus.
area.
Spinal
Mandibular area.
nucleus
Hmm?
of fifth.
This may indicate the onion peel involvement, where the mandibular area will be earlier affected than the central area.
Yes.
The periphery will be affected earlier than the central area.
Yes.
So it could very well be due to a
High cervical.
high cervical. Otherwise, you have to go to very high up in the
Medulla.
medulla. Could also be due to a medullary lesion, but if a person has no other medullary involvement evidence and the pain is lost from the mandibular area, means that from here, periphery. Patient will say that from here you think that it's mandibular, but actually it is the periphery.
Yes.
This may be due to the
High cervical.
high cervical lesion. And the nature of the lesion?
Intramedullary, sir. Like
Ah,
in the
I-
central part, sir.
Unfortunately, I am biased.
Cent-
Because of the man and succulent. Even an intramedullary tumor won't produce this side. It's likely to be a syringomelia with a
High.
syringo
Bulbia.
bulbia. Syringo would be extending to the.
So what about the sensory over the nape of the neck? Have examined that? You are telling syringomelia. Have examined for that suspended sensory loss.
It is
What is
there,
that?
sir. From C2 till T2 level, he has lost. Sir.
That you have not mentioned, I think.
Ah, it is there, sir.
Yes, mentioned. It's a headache. Do you think that it is the neck strain? Is it cervicogenic? Lying down, he is getting headache. If it is correct, you have to think of an associated problem of hydrocephalus. He has a hydrocephalus, which is. Will a syringomelia as such produce a hydrocephalus?
No, sir.
No. So what may be the associated lesion?
CVJ anomaly.
What CVJ anomaly?
Arnold
Chiari. Huh? Now, do you think that the torticollis is muscular? Muscular means that it is usually fixed. This I saw that it's very well corrected. See, usually in younger people, Arnold Chiari 1, type 1 ACM, when it is peg-shaped, one manifestation is torticollis. Am I correct? In children, torticollis is, why, if it is in children, why can't it be in adult? Manifestation of it. Now your giddiness, can you discard it as just positional? Always these problems are usually associated with the other craniovertebral anomalies like assimilation of the vertebra, blocked vertebra, etc., which may produce associated. Even without that, Arnold Chiari and Sergomelia are associated with vertebrovascular insufficiency. So all these symptoms which he has said should have
the investigation. See, sometime back there was a discussion that if the patient develops a new deficit or the existing deficit worsens following Valsalva, you can reasonably come to a conclusion that it could be syringomelia.
Yes.
But in spite of these things not occurring, still the patient may have a very slow indolent course of worsening or progression of the disease. Can you explain why?
Usually they are associated to blockage, sir, of this foramen of Megandian Lushk. If there is, it is a primary.
No, unless the syrinx doesn't progress slowly, it does so very slowly. Okay, suddenly there can be sometimes what to call this Valsalva maneuver or sudden dissection into the spinal substance can cause acute worsening.
Yes.
But it most often doesn't happen that way, occasional. But in majority of the cases, the progress is slow, indolent, over a period of years. How does it happen? Why does it happen?
So there are some Virchow-Robin spaces. Sometimes they open up and take the
No, this is the basis of Dorfman and Oldfield's theory of
piston
series. What is that?
During this sudden maneuver, sir, of raised IC.
No, it's not maneuver. It is CSF pulsations. Constant CSF pulsations are responsible for the development of or progression of syrinx.
That is Gardner's theory, sir, from choroid pulsations. Sir. Gardner's theory, they have given us choroid pulsations, sir, which
Okay, we will move fast. You are allowed to have only one investigation. What investigation will you do?
Imaging, MR imaging.
MR imaging of?
Spine, sir. High spine, cervical spine with high cervicovertebral junctions.
Wrong.
Cranioid.
Wrong answer.
Sir?
Wrong answer.
Wrong answer. Okay.
Modify that. You have to see not only CV junction, but also brain. Why the brain?
Hydrocephalus.
Hydrocephalus and other associated abnormality which may require interventions. I am not happy with the brain alone. You will go for a
whole spine.
Huh?
Whole spine.
Whole spine, no problem. I don't expect a fine expending up to. It doesn't surgeon. It doesn't matter whether it is all hollow cord or not. But one more thing, we want to know the status of vertebral artery, isn't it?
Yes.
What is the position of the vertebral artery? Whether there is a kinking, whether there is a dissection, and all. Also, always remember that a CV junction problem, when you expect, you have to go for not only cervical CV junction, but also for the brain, but also for the vertebral artery. After the brain MRI, you are allowed one more investigation. What investigation will you do?
Fundus, for raised.
Fundus, clinical examination. Fundus is not an investigation. I will go for a CT scan of the CV junction also.
Yes.
CT scan, because it will be very useful for the surgeon or ourselves to know the other associated bony abnormalities of the CV junction, as well as the position of the vertebral artery, where is the site of groove. Surgeons classify them according to the position, and whether the surgical correction will result in damage and all. That is what I want to emphasize. Not only a CV junction, MRI, and don't get happy with that.
After doing MRI, why do you think a CT-CV junction is essential?
Bony abnormalities are better in CT.
Okay. See, when you deal with a case of CV junction, especially Arnold cherry malformations or any atlantoaxial dislocation, three things are absolutely important. Number one, CT-CV junction, CT vertebral angiogram, and then MRI. So without these three, I don't think one should proceed further with surgery.
It's not our field. Still, I shall ask you one question. What is PBC2 line or distance? Small letter P, then B, then C2 line. Because in such a case, surgeons are always bothered about this line also, isn't it? Read that, because medical field we don't see that. It is a line to see whether the atlantoaxial, the odontoid is tilted posteriorly, especially in especially in Arnold cherry and syrinx. They want to know whether it is retroflexed or not, and the management depends on that distance. If it is more than 9, there should be definitely a surgical indication is there. So that line we should also be aware, not only neurosurgeons.
Doctor, what are mirror movements?
Synkinesias.
People climbing the ladder. When they put one hand, automatically the other hand also goes. So they cannot climb the ladder. So alternate usage of limbs will be difficult in a person having CVG anomalies who have mirror movements. Okay.
Mubashir, it's a case of syringomyelia, syringobulbia. The gold standard test is MR imaging. Finished. That means syrinx means cavity, cavitation of the spinal cord and brainstem. That means of syringomyelia of central origin, CNS.
Yes.
Have you heard about the syringomyelia of peripheral origin? I mean to say pseudosyringomyelia.
Yes.
See, final test is imaging. Nobody is examining in detail, taking 2 hours time.
Yes.
Okay, very good. And you know the difference between hydromyelia and syringomyelia?
Yes.
What is the difference?
Hydromyelia is ependymal lined cavity, sir. Ependymal lined cavity, sir. And usually it is central, primary, less than 3 mm.
So a cavity lined by ependyma is hydromyelia.
Yes.
A cavity lined by glial layer is syringomyelia.
Yes.
Very good.
Any other comments from audience?
Syringomyelia produces dissociated sensory loss.
Yes.
Any other brainstem lesion can produce dissociated sensory loss?
Even lateral medullary syndromes, anterior spinal artery infarctions can also produce. Brown-Séquard syndrome. Reverse dissociated sensory loss, sir. Even in high medullary lesions, it can be a false localization.
Actually, we are running short of time. I will just, I have one question for you, short question. Can I, sir?
Oh.
What are all the set of radiological investigations you order for a CV junction case? What are all the set of radiological investigations you order for a CV junction case? Please tell me.
So CT scan of CVJ, like the sir told us. CT scan of CVJ with CT angio of vertebral arteries and MRI.
That's all? Anybody? Anybody from the group? Neurosurgery residents especially? Neurosurgery residents? X-ray flexion extension. Next. X-ray flexion extension CV junction. Next. Neurosurgery residents. Please tell me. CV junction case, what are the investigations? Tell me, get loudly. Next. What else? CSF flow study, very good. Next, CSF flow study across the syrinx, across the CV junction. Next, come out. Flexion extension MRI is also being done. Dynamic MRIs to know about the ligamental status, how to deal with the ligaments. Because compression is done by the bones, ligaments, extraaxially, and within it, syrinx. So compression and insult to the neuronal tissue is extrinsic as well as intrinsic. So we need to know the dynamic MRI also for the CV junction. Now we are doing it. And the next is dynamic CT is also being done to plan for the screw trajectories, C1, C2 lateral mass, occipital cervical fusion and all. So set of investigations briefly, flexion extension X-ray CVJ, MRI CVJ, along with brain to load hydrocephalus. Because if you alone do the CVJ repair, if there is a hydrocephalus, there will be a lot of pressure above and it will lead to CSF leak post-operatively. Thank you.
So we shall stop. What was MRI like?
You have the access. Next. 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 Next.
Some more sagittal sections are to be.
Keep that one. Next, one more. Previous. No. Not. Next. Previous one. What is your comment about this MRI?
Sir, first there is loss of cervical lordosis.
There is a syrinx. There is a syrinx.
Yes, sir. Syrinx.
Any Arnold Cherry?
There's no bulbia, sir, here. No bulbia here.
Any ACM?
No, sir. No Arnold.
No ACM.
But
Any peculiarity of the CV junction?
Sir, one thing is there's one dilated cavity high above also, sir.
Dilated?
Cavity high above also, sir.
Where?
CSF flow problem is there, sir. Signal flow.
So, what I feel that the posterior fossa is crowded.
Yeah.
Crowded.
There is a low-lying tent, and the tonsils are normal in position. The C2 is retroflex and a lot of compression of the brainstem. Syrinx is its cord is also. I think it's a burnt-out syrinx.
Yes,
I think he would have had a syrinx which now it has come down.
So this may be called as Arnold Cherry type
0. Yes.
So we will close this one because of the shortage of time, and very good presentation. He was asking whether you will give a pass or not. I told him that I will definitely give you a pass. Okay.
Due to the strict norms of NMC, I request all the delegates and faculty members to kindly provide accurate details at the registration counter and do sign on both the days as attendance is strictly monitored. Please everyone kindly keep your phones in a silent mode and kindly cooperate for this.
Next presentation, I request Dr. Ramesh Naik sir and Dr. Chandrababu sir to chair the session. And I invite Dr. Ashish Atre sir to discuss on spinal cord imaging.
Divya and Ashrita to tell me that when they are bored and hungry, we will stop this talk and we will continue with lunch. So because you were discussing CV junction and the imaging, I thought I will just show you a case which is hot from the oven, which I had prepared from another talk. So this is a 25-year-old lady who had headache, which was more on flexion and had no neurodeficit. So these are the imaging of this lady, and what patient's CSF flow study clearly shows that there is obstruction to the flow of CSF at the level of foramen magnum. No big deal, the structural imaging had already shown me this, so you have really not changed anything by doing this CSF flow study. I buy your idea and I say that yes, there was nothing much to be done by this additional investigation. But look at this case. This is a 44-year-old lady who has come with headache, right-sided hearing loss and tinnitus. Audiometry showed sensory neural deafness as well as conductive hearing loss on right side, and that's why she was advised MRI. So she was advised MRI basically for headache and sensory motor hearing loss on right side. What does her MR show? Her MR shows that the cerebellar tonsils are plus minus. They are not as down as they were on the case before. But interestingly, apart from those white matter lesions, which are a little unusual for a 44-year-old lady, what we are seeing is an incidental finding of this syringohydromyelia. I really don't want to say whether it is syringomyelia or hydromyelia. It is more of a theoretical discussion. What we are seeing is a cavitation in the cord, which is which we are seeing as an incidental finding. Now comes the question, what do you do about this patient? Would you operate this patient considering that there is borderline tonsillar ectopia, or you say that I don't know the cause of this syrinx and that's why I will not operate, especially because the patient does not seem to be symptomatic for that syringohydromyelia. Now here comes the role of the neuroimaging technique. We obviously followed it up when we saw this on the MR of brain. We followed it up on cervical spine MR, and you see a large cavitation with cord expansion extending from the cervicomedullary junction almost till the upper thoracic level. So there is no question that this is syringohydromyelia. Now comes the question of decision making. Now if you see this scan, which I have just blown up image of the same image that we saw before, you clearly see that the posterior subarachnoid space here at the foramen magnum is very well maintained. The anterior space is little bit effaced, but if you really look at it, there is no cervicomedullary junction compression. Would you agree with me? And you would say that this does not seem to be the cause of syringohydromyelia. Am I fair in saying this? Or are you fair in saying this as a clinician? Now comes the role of the CSF flow study. What do we see on CSF flow study? We see that CSF flow in neutral position is normal. We are seeing good flow anteriorly, we are seeing good flow posteriorly as well. There does not seem to be any obstruction to CSF flow in neutral position. That's how we will do MR, generally MR CSF flowmetry in cervicomedullary junction. What happens in flexion? This is a thing that I have been doing off late routinely. What is happening on flexion? These are the flexion images, and if you see the flow, in fact, as compared to the previous scan, the flow here is enhanced. In flexion, where we expect, for example, in C1, C2 subluxation or dislocation, what happens in flexion position is actually there is narrowing of foramen magnum, and that's why the CSF flow is actually obstructed. What is happening here? In flexion position, actually the CSF flow across foramen magnum and in fact foramen of Magendie is enhanced. It is more marked. So that probably told me that this may not be the cause. But I wanted to become smarter on this occasion, and I said, why not do this in extension position and look at the CSF flow. And what happens in extension position? There is absolute obstruction to CSF flow both anteriorly and posteriorly, and this was an additional exuberant bone formation along the posterior arch of atlas, which was causing cervicomedullary junction narrowing, which was only getting enhanced on extension position, causing obstruction to CSF flow, and that's why causing syringohydromyelia. You would obviously say this is all theory, whether it really worked or not for the patient. So patient, this is what we reported, and this patient underwent decompressive surgery. There you can see a pseudomyingocele, and best part was that patient was anyway asymptomatic for that syringohydromyelia. But after surgery, for some reason, his sensory neural hearing loss improved, and the patient, she is very happy with it. But what I wanted to make a point is that CSF flow study, as some resident mentioned, in CV junction evaluation are forming an important part of investigation. So this was by the by. Now we move on to the basics of spine imaging, and we will do in next 25 to 30 minutes the best we can. This is again not an encyclopedia, neither is a comprehensive review. This is just to show you that spine imaging is not really difficult and it is interesting. at the same time. Now, this is one area where really we don't have any role of, there is no competition for MR, because when you are evaluating spine, once you move on from plain X-ray, except for rare indications like CV junction evaluation, CT and PET CTs and etc. do not play much role. So, MR, spine symptoms is equal to MRI if X-rays are normal is the reality. Also, we have to remember that everyone has back, and when it starts aching, it becomes the back, and that's why because everyone has a back, it has to ache, and it is a significant burden on the healthcare system, and that is backache. So, because I thought I'll include this few non-neurological part of the imaging as well, because there was a lot of neurosurgery residents in the crowd, and I feel it is important that we figure out the cause of patient's backache, because if we can't, then they make the doctors as well as their spouses' heads ache. So, evaluation for backache is an important part of imaging. At the beginning, we should also know that what is not abnormal, because otherwise we will call things which are normal variation also as abnormal. One of the things is the common artifacts, and the commonest artifact and the mistakes that happen is when we see this so-called abnormal channels of flow voids in the dorsal CSF or posterior CSF of the dorsal cord. Now, this is not AVM, this is not dural AVF. These are normal areas of spinal flow because of the septum posticum and the cardiac pulsation. There is tortuous flow of CSF around the septum posticum. This is what causes this apparent abnormal signals or filling defects in the posterior CSF in the dorsal cord. It is a normal finding, not to be mistaken for AVM. Another finding is called, another artifact which is called truncation artifact, which is mistaken for syringohydromyelia. How it looks? It looks as a central area of T2 hyperintensity, generally seen only on T2 weighted images. We do not see it on T1 weighted images, and the way to get rid of this artifact is to improve your image quality by improving the number of averages, and this artifact generally disappears. How do you know that this is an artifact? That it is only present on T2, you do not see it on T1, and you enhance your image quality and the artifact disappears. If that is an artifact, is this reality or not? What is this? Here you are seeing a central area of cord cavitation, right? We are also seeing it on axial plane, so this is not an artifact. So what is it? Will you call it syringomyelia, syringohydromyelia? Is it normal variation? Is it to be followed up? What do I do with it? This is something called prominence of central canal, which is a normal variation. It is seen in up to 2% of population. It is huge, 2 out of 100. And how do you know that this is not syringohydromyelia? There is no sure shot way of knowing that this is not going to progress to syringohydromyelia, but imaging wise we call it as a normal variation or dilatation of central canal till the time the diameter of this cavity is not more than 2 millimeters. So 2 millimeters is the cutoff. If the cavitation is more than 2 millimeters, we do not call it prominence of central canal, we do call it syringohydromyelia. While at this stage, because it is less than 2 millimeters, I am safer in reporting it as a normal variation, but at the same time, I cannot be sure that this is not going to progress to syrinx, so we will have to do a follow-up MR and see if it progresses or not. On most of the occasions, it will not, because it is a normal variation. Now let's come to some case scenarios of backache. Now these are two patients, this is the first one, who are presenting with severe backache. What do we see? We are seeing that there is some area of signal alteration at L5S1, you agree with me? There is some hypointensity on that T1 weighted images, and what we call that fat suppressed T2, or what we call them as STORT tau inversion recovery images, which bring out the bone edema best. We are seeing this area of hyperintensity beneath the adjoining end plates, right? And this is the axial image not showing much. So this is the first patient showing marrow signal alteration and the associated marrow edema. This is another patient showing almost similar findings, area of marrow signal alteration, identical location, L5S1 disc, similar kind of edematous changes in the marrow on the STIR images, and we are seeing some amount of surrounding edema or soft tissue. Again, the axial images not contributing much. So, both patients are coming with severe back pain. My question to you is that amongst the patient 1 and patient 2, between these two patients, who has pyogenic infection, who has COX, whether patient 1 is pyogenic, patient 2 is COX, patient 1 is COX, patient 2 is pyogenic, both are brucellosis, or none of the above is true. What would your answer be? Very good. And why would you say that? This is the most correct answer, and I want to make this point at the beginning of my talk. Why would you say that this is not infection? Whether it is brucellosis, whether it is tuberculosis, whether it is pyogenic, doesn't matter. You and me are never going to know till we get a microbiologist to examine the specimen and say what it is going to be. But important thing to tell that this is not infection, and that's why this patient does not need aspiration or biopsy of that tissue. So what tells me, let's go back. What are we seeing in these two patients? We are seeing marrow edema, which is almost always seen in any infection of the spine. What are we seeing interestingly, if you make this bigger, is that this disc, which is also involved, is actually reduced in height, and unlike the other discs, which are bright, is actually becoming dark on these T2-weighted images. So it is a dehydrated disc. Right? In spinal infection, the disc which is infected always turns bright. In both these patients, the disc, even though the appearance of the vertebral bodies is ghastly, the marrow edema is fearing, the important thing to look at is the disc, and if disc is reduced in height and is dark on these T2-weighted images, these patients are unlikely to have infection. These changes are degenerative and are called modic type 1 or type 2 changes. Okay, this is to show you the same difference. Now this patient is degenerative while this patient is infected. Look at the difference between L5S1 disc here and the L45 disc here. The L45 disc here is swollen and is bright, while the vertebral appearances are almost identical. So look at the disc, reduced, dark, likely to be degenerative, fattened, bright, likely to be infection. Okay, but of course there are more clues than that. You don't have to every time go to the disc. You obviously have more clues, especially if you give contrast. For example, this patient has this affection of L4 and L5 vertebrae. The intervertebral disc space is reduced, but if you look at the rest of the findings, what are you seeing? A large amount of paraosseous soft tissue which is enhancing, a central area which is not enhancing, so it is an abscess with surrounding granulation tissue. If you see this along with vertebral involvement and a bright disc which is enhancing, you know that this is going to be an infective etiology, and this turned out to be pot spine. Now sometimes when you are looking at these spinal images, it is worthwhile to look at surroundings, because the clue to pathogenesis or the etiology could be in surroundings. Most of the infections of spine will have similar appearances, so that's why you have to look at surroundings, and that could give you a clue sometimes. This is a 47-year-old lady whose only complaint is backache. What do we see? We see that there are multiple vertebral affection. Entire vertebral column is looking very heterogeneous. This is not how a normal vertebral marrow in a 47-year-old lady will look. It is going to be more fatty. We are seeing these multiple focal lesions in the vertebral bodies. Now when we look at her coronal images, which are also part of the spine protocol, do you find anything which is abnormal? Yes, we do. If we look at the spleen on the left side, we see that there are multiple tiny lesions in that spleen, right? This is liver, that is spleen. I must explain that to the neurologist. So there are no liver lesions, but there are splenic lesions. Now this generally doesn't happen with metastatic disease, right? Liver is the preferred site for metastasis. Spleen is very rare unless you are looking at leukemias and lymphomas. So this is not metastasis. One more finding is that if you look at the pleural cavities, the left pleural cavity is very clean, while on the right side there is this hyperintense signal telling you that there is right pleural effusion. Combination of multiple spinal lesions, multiple splenic lesions, associated pleural effusion, what would you put it as? Not really, I will put it at COGS because multiple myeloma again does not affect spleen. Spleen is a very, very rarely affected organ in case of neoplasm. This is again turned out to be COGS. This patient was seropositive and this again turned out to be COGS. So looking at surroundings like the splenic lesions here are pointers to etiology sometimes. Now things are very straightforward on most of the occasions. This is a patient with acute onset of pain in both lower limbs, also had numbness, urinary hesitancy in this 25-year-old lady. What would you put it as? A young lady, acute onset symptoms, has pain, has numbness. What clinical diagnosis would you put it as? It would be obviously a large extruded disc, right? Everything fits in line. She has had acute onset of pain. We see this huge extruded disc which is causing severe compression of the thecal sac there. So things are pretty much straightforward here. So radiological diagnosis is in line with clinical diagnosis. Sometimes they are a little difficult or a little dissociated, and this, as in this patient, acute onset of right-sided pain and right foot numbness. So symptoms are right-sided. This is the midline sagittal image of T2 weighted image of the spine. Does it show anything? Does it look normal? Is it abnormal? It looks normal to me. There is nothing really there. So if you can't explain, we love the midline images because the contrast is very good. We see the CSF very white, we see the conus, we see the cauda equina nerve roots, and all of us look at these midline images and see whether there is a large disc or not, whether there is a compressive pathology or not. But when the patient's symptoms are unilateral and you are not seeing the cause on these midline sagittal images, it is worthwhile to look at some of the parasagittal images. And the parasagittal images give you the answer to the story that there is a paracentral extruded and migrated disc which is causing compression of this traversing right S1 nerve root, explaining the patient's symptoms. Things can become really difficult, as happened with this 48-year-old man presenting with left-sided leg pain and numbness. Now, if we see the parasagittal images here, the midline sagittal and actually the parasagittal images is very, very, very normal. These are the far lateral images which show you that there is a foraminal disc extrusion at L4-5 which is causing compression of the nerve root. And the important thing for residents to understand and look is that in normal neural foramen like this, there is fat which is all around and a central filling defect which is the nerve root, as we are seeing here. So if that is obliterated, as is happening here, you know that this is a foraminal disc which is compressing the nerve root. The neural foramina should look like this. The fat in the neural foramina is the guiding light for us to check whether there is foraminal disc or not. Now sometimes one has to be really lucky and see such scans early in the morning, because later on in the day it is impossible to pick up these findings and think logically. This patient has an acute onset of right-sided hip pain. He is a 30-year-old gentleman. On examination, he has weakness in his right hip flexors. What do we see? We see a focal lesion in the conus or in relation to the conus. It is hypo-intense on T2, it is iso-intense on T1, enhances brilliantly, right? So pretty straightforward thing. It is going to be a conus tumor. No questions asked. My question is, am I happy at looking at these images and correlating them clinically? Or do I have to look at something else to check whether patient's symptoms can be explained by this lesion? This is a central lesion, almost in the center of the spinal canal. We are seeing right-sided flexor muscles, so hip flexor muscles. What is likely to be the root value of hip flexors? L1. Where is the lesion located? L3. Does it explain L1 weakness? It does not. That's why you have to look at the parasagittal images to see that there is a foraminal disc on the right side which is compressing the L1 nerve root, and that is responsible for patient symptoms, and not the conus tumor, which is an incidental obvious finding, striking obvious finding. That's why I said these cases you have to see early in the morning when you are reporting. You have to be just fortunate to get them early in the morning, otherwise later in the day obvious things become more obvious to you. Okay, history can sound very similar to disc pathology, as happened with this 54-year-old executive who complained with acute onset of low back pain, which happened when he was straining for stools in the morning, which was followed by bilateral lower limb weakness and lower limb pain. He had urinary retention, for which he underwent an MRI. This was his initial MRI. And initial MRI, the clinical diagnosis obviously would be a large extruded disc, right? But the initial MRI is not, does it show anything? Nothing. So what do I do? Which looked essentially, this MRI is essentially looking normal, patient is symptomatic, clinical signs are there. So do I have to do any more imaging, or I just say, I don't know why you have these symptoms? Okay, what we did is that we did diffusion weighted MR imaging, and what it shows is that there is a focal area of diffusion restriction in the conus. This typically happens, this is typical of a conus or lower dorsal cord infarct, and that classically happens during discogenic embolus in the anterior spinal artery, and we actually are not, many times may not see the causative disc, because there is a small nucleus pulposus protrusion which actually embolizes in the anterior spinal artery and causes this infarction. So we have to add this diffusion weighted MR imaging sequence if we can't explain patient symptoms which are so objective. Other common indication, of course, in spine is presence of neurodeficit, which could be due to compression, and the compression could be extradural, due to extradural pathology, intradural pathology, or it could be an intramedullary lesion, as we saw in this case of conus infarct. Before we go there, what I want everybody to understand, especially because this is a huge postgraduate crowd, is how do we localize and compartmentalize lesions on MRI? So how do we say that the lesion is in the extradural space, which is intradural extramedullary, or it is intramedullary? And is this distinction important? So first, let's answer the second question first, is this distinction important? Oh, I'm already up with my time? Oh wow. So let's first understand whether this distinction is important. I thought you will give me advantage for that initial thing of not being part of my talk, but anyway, it doesn't matter. So is this distinction important? Okay, so this distinction is theoretically and practically, according to me, is important, because the etiopathogenesis that you are going to propose is going to be based on which compartment you localize a lesion. For an extradural lesion, you cannot call it an astrocytoma, right? As against that, an intradural extramedullary lesion is likely to be a nerve sheath tumor or a meningioma and not an ependymoma. So localization of lesion is very important. How do we do it? So this is the first set of MR images. You always look at the anterior or posterior CSF space based on where the lesion is located. What is happening in this patient? If you look at the anterior CSF space here, at the site of pathology, the CSF space is getting thinned out or effaced. Okay? That means something is coming from outside and causing thinning of the CSF space. If this happens, the lesion is likely to be in extradural space, that is outside dura. As against that, look at this set of images. Here, the lesion is posterior. I have marked it for you. Now keep on following this subarachnoid space above and below this lesion. The subarachnoid space, as it gets closer to the lesion, starts becoming wide. Okay? The subarachnoid space, which is thin here, as you go close to the lesion, it is becoming wide. That is called the arachnoid cap sign. That means the tumor is bathed in the CSF from above and below. That's why it is forming a filling defect in the CSF space, and the CSF space above and below is widened. This is also called meniscus sign or arachnoid cap sign, localizes lesion to intradural extramedullary compartment. As against that, if a lesion is intramedullary, what it is doing to the subarachnoid space? Look at this subarachnoid space. You can see the subarachnoid space here and here, but where the large tumor is there in the cervical cord, the subarachnoid space is hardly seen or thinned out or effaced on either side. That makes the lesion intramedullary. Is the distinction very clear? Okay. Now, extradural lesions can be caused by multiple things. One of them is, of course, as regards the intradural extramedullary tumors, we saw the nerve sheath tumors and meningiomas are the common ones, and they look like this. They enhance brilliantly and they form this arachnoid cap sign. Moving to the intramedullary lesions, which can be caused by multiple causes like inflammation, trauma, vascular, congenital, or space occupying lesions like brain, we follow. I am just going to discuss this pattern and then stop. How do we analyze this cord signal changes? Now, what as a radiologist we do is we look at how is the cord involved. That is because each disease has kind of a pattern of involving cord. As you would know, the clinical examination and the history many times is very similar in many of the spinal conditions. It is not as good as brain. Most of the spinal pathologies cause similar kind of symptoms. That's why pattern analysis becomes very important on MR in spinal imaging. So what do we first look at? We first check whether the involved segment of the cord, which is appearing hyper intense on T288 images, whether it is involving a short segment of cord or whether it is involving a long segment of the cord. If short segment definition is less than 1 vertebra, while long segment definition is more 3 vertebral bodies. So in between, you can subjectively say whether it is long distance or short distance involvement, but how is it important? Now, short segment involvement of cord is characteristically caused by lesions like, say, demyelinating plaque of multiple sclerosis or anterior spinal artery infarct. As against that, a neuromyelitis or optica spectrum disorder tend to involve a cord over a longer segment. Similarly, longitudinally extensive transverse myelitis is also a feature of autoimmune spinal disorders. So that's how it helps in knowing the size of the involvement. Then we see on axial images how much of the cord is involved. Is it only one side of the cord is involved or both sides of the cords are involved? If it is involving only one side or it is partially involved in the cord, we see if it is only involving one half of the cord, it is very typically seen in one cross section, only one plaque is a typical feature of multiple sclerosis. As against that, if the lesion is involving central part of the cord like this, involving both halves, it is more commonly seen with acute transverse myelitis or in NMO spectrum disorders. If the cord is partially involved, next thing we look at is which part of the cord on axial image is involved. Because there are specific things which involve specific structures. For example, if you see a cord involvement which is predominantly in the anterior horn cell area on either side of the midline, you could think of, say, motor neuron disease or amyotrophic lateral sclerosis, or you could think about the anterior spinal artery infarction or enterovirus related myelopathy. So all these will involve the anterior part of the cord in the region of anterior horn cells. If you have the dorsal cord involvement on either side of the midline, you would think about, say, vitamin B12 deficiency myelopathy or HIV myelopathy. If you have a plaque which is oriented in a triangular fashion with broad base towards the meninges, you are more likely to think it to be of MS plaque. While if you have a large plaque like this, which is occupying almost the entire area of the cord and is more located in the central part of the cord, it is a feature of, say, NMO spectrum disorder. So how the cord is affected in axial images gives us a clue as to what could be the etiopathogenesis. The next thing we look at is the affected cord swollen or is it atrophic? Because if the cord is atrophic, we know it is a long-standing disease which has led to myelomalacia and probably is a non-treatable stage now. While if the cord is swollen, that means there is some active pathology going on in the cord. cord swelling is classically seen with anemospectrum disorders, with also seen with tumors, with acute transverse myelitis or infective myelitis as well. Okay. Another important thing to look at is whether the cord lesion is enhancing or not. Now, this enhancement is not as generic as in brain tumors. In brain tumors, enhancement plus minus really does not change our diagnosis from tumor to non-tumor, because a lot of brain tumors don't enhance. But that is not true with spinal tumors. Nearly 99% is almost everybody, right? Nearly 99% of spinal tumors enhance. So what you are doing by saying that an expanded cord is non-enhancing, you are almost ruling out tumor. So that is the importance of enhancement in spinal cord. And of course, we look at lesion multiplicity, and are there any lesions anywhere else like in brain which could actually give you a more likely etiopathological diagnosis, because the lesion morphology in brain is more specific than in spinal cord. So you have to look for lesions beyond. We will just see a couple of examples and end there. A 32-year-old lady presenting with tingling numbness in the left upper limb. What do we see? A small area of cord signal alteration. How is it located? It is on both sides of the midline or one side of midline? Only on one side. How is the orientation of this lesion? Apex towards the central canal and broad towards the CSF, right? If you add that to presence of optic neuritis or on one side and presence of a small periventricular plaque, you put all this together and say this is likely to be multiple sclerosis. Now, this is a 36-year-old lady presenting with slowly progressive quadriparesis. How much segment of the cord is affected? Short segment or long segment? Long segment. Very good. Is the cord swollen? Yes, it is swollen. Is the cord enhancing? Yes, it is enhancing. Yes, give me 2 minutes and I will make my point and leave the stage. So, the cord is enhancing. Have you ruled out neoplasm? My question is contrary, right? What I am saying is, have you ruled out neoplasm? No, because this is a teaching class, I am going this way. So, you have not ruled out treoplasm just by the fact that this lesion is enhancing and cord is expanded. Did it turn out to be neoplasm? No, this is not, because this is a typical appearance of anemospectrum disorder. Now, why I say this is a typical appearance? Whenever you see anemospectrum disorder enhancement, first of all, there is a longitudinally extensive transverse myelitis, more than 3 segments of the cord are affected, cord is swollen. If you look at the pattern of enhancement, how is the enhancement? Does the enhancement look like this? Fat in the middle and tapering towards ends? Does it look like this? What we call as a cigar shaped enhancement. Now, this is typically seen with anemospectrum disorders, and this is a diagnosis which you should keep in mind before calling it tumor, because a simple therapeutic test, of course following lab test, a therapeutic test of steroids or immunomodulators will prevent this patient from undergoing surgery or a biopsy or a myelotomy, which will almost always leave him with a neurodeficit. So, identifying disease pattern and suggesting it is important, and not calling this tumor was an important part. And why I did not call it tumor was because I saw another lesion in the brainstem in this patient, and of course, this is a post-treatment scan where you see resolution of all that cord signal abnormality, proving my point. Yeah. Now, closest differential to this, of course, is acute transverse myelitis and ADEM. Now, this is a patient with acute transverse myelitis, again a longitudinally extensive cord signal abnormality. Here we see enhancement of cauda equina nerve roots, and we also see enhancement of the cord substance. I think this will kind of, should we see one quiz and end this, or let's end it here? Quiz? Okay. We will end it with a quiz. A 16-year-old boy who is a basketball player had a history of fall, which was followed by backache and heaviness in his right limb. A 16-year-old boy, a young kid. This case is a good quiz case because it will kind of summarize what we have done in the first part. So, first things first, where is the lesion? Let's localize it first. So lesion is here, it is obvious, right? There is something going on wrong there. I will just blow this image up, the T2 weighted images. What is happening to the posterior CSF space? Look at the space here. Is it becoming wide at the interface? It is, like it is forming that meniscus sign or arachnoid cap sign, telling you that some part of this lesion at least is in the intradural extramedullary space. Oh shit, I'm sorry. Okay. So part of this lesion is in the intradural extramedullary space, correct? Okay. But apart from that, we are seeing that there is something which is above that level, which is causing cord thinning, cord expansion and actual thinning of the subarachnoid space. So there seem to be two lesions. One is located in the intradural extramedullary space that we saw here, and above that there is one more lesion which is seems to be located in the intramedullary space. If you don't agree with me, I will show you the contrast scan. So we are seeing one lesion which is flushed with the posterior dura and one lesion which is within the spinal cord, right? So there are two lesions. So what is it? A 16-year-old boy, basketball player, probably incidental. Is it demyelination? Why not? We can't explain intradural extramedullary lesion, right? We could have explained the intramedullary lesion. So localization of lesion is very important. Because we have localized part of the lesions to intradural extramedullary compartment, demyelination is out of window. Can it be metastasis? Why? He's a 16-year-old boy. It's unlikely to be metastasis, but possible because they also can form intramedullary as well as intradural extramedullary lesions. Can it be ependymoma? 16-year-old boy, yes, definitely possibility, but ependymoma also can be in two compartments because they can arise from the conus where they are intramedullary and from the cauda equina nerve roots where they appear to be intradural extramedullary. Actually, there is no medulla there, so they are basically intradural lesions there. So the last possibility that I want to discuss is actually lymphoma. That is because he is a 16-year-old boy and we know some of the childhood malignancies are leukemias and lymphomas. Can it be meningioma? Again, intramedullary lesion we have localized, cannot be meningioma. So our two diagnoses that are remaining are either ependymoma or it is a lymphoma. So we do a diffusion weighted MR imaging. You know, lymphomas are highly cellular tumor. They light up on diffusion. So what does this show? Again, this shows two lesions, one in the intramedullary, the other one in the intradural extramedullary space, both appearing extremely diffusion restricted. This did turn out to be non-Hodgkin's lymphoma. So that's about it. What I will do is we will just end by so the carry home message is spine imaging is quite easy. One has to know where to look at and what to look for. Spinal pathologists could have very similar history. Sometimes etiology, as we saw, is in the surroundings, and expert eyes tend to see more than the non-expert ones. Thank you so much.
Thank you, sir, for your lucid presentation. I think if Ramanamurthy permits, I would end the session here. Thank you.
If you see the blood supply, you know that all the interventions are there after the brain for its blood supply, its infarctions, its problem. You see that the blood supply of the spinal cord, such a vital structure, is so simple. At the top, you will see what is anterior spinal arteries, and the lower down you see the artery of Adencuis. It divides and blood supply goes up. From here blood supply comes down, and you can see that there is a watershed area in between at the thoracic level. Such a simple blood supply, and intrinsically also this is a very simple. There is a bile plexus This is the plial plexus. Then you can see the sulcal artery which supplies the grey matter. The plial plexus supplies the white matter. It is arranged so simply. But you know that a lot of diseases are there which affects the spinal cord. Not only that, in the examination you know that all sort of questions are coming from a spinal cord, so it becomes sometimes not so simple. So make it simple, we will see how will you approach the spinal cord localization. For this, I will say that I used to classify the spinal cord into two. One is localization of the upper and middle spinal cord, that is cervical and dorsal. The second is localization of the lower spinal cord, which is lumbar and sacral. The upper spinal cord segment produce what is called human paraplegia with a level. The lower spinal cord produce what is called a element paraplegia, and it is diagnosed by its pattern. Remember that when you think of spinal cord, you always think it's a paraplegia with UMN signs, isn't it? You all think that spinal cord means UMN. But remember that the lower segment produce not UMN signs, but it produce LMN paraplegia. This is the main differentiation. Decide whether it is UMN or decide whether it is LMN. Now, first we will go to the localization of lower spinal cord, that is lumbar and sacral. As I have already said, it produces UMN paraplegia, and the identification is by its pattern identification. What you see that in a spinal cord suspected disease, paraplegia with LMN side, then you decide that under what pattern the clinical feature is coming. The anatomy, there is what is called epiconus, constituted by L4, L5, S1 and S2. Clinically, usually the L3 is involved. Usually the L2 also is involved. So the epiconus for clinician may be L2, L3, L4, L5, S1 and S2. Strictly speaking, anatomical terms it is L4, L5, S1 and S2. And then comes the conus, which is S3, S4, S5 and coccyx. PGs usually add S2 also, but S2 won't come under conus. And then comes the cauda equina. Roots below L2 is called cauda equina. So this is the anatomy of the lower spinal cord. Now, the pattern, you can identify 6 patterns in lower spinal cord, that is lumbar and sacral segment. One is what is called conus pattern, then conus cauda pattern, full epiconus pattern, full epiconus pattern, lower epiconus pattern, upper epiconus pattern and radicular pattern. Remember that these are all patterns. These are not sites or diseases. You can identify this pattern in the lower spinal cord and identify the pattern first. What is the conus pattern? That is lesion of the S3, S4, S5 and coccyx produce conus pattern, which is characterized by an LMN bladder, a saddle anesthesia, lax external anus sphincter, absent anal and bulbocavernous reflex, absence of lower limb weakness. When you see such a pattern, you call it as a conus pattern, and the conus pattern is produced first by a conus lesion itself in the spinal cord, or it could be produced by a lesion of the central cauda equina affecting the roots arising from the conus. So that pattern means you have to look for those 2 sites. The next pattern is what is called conus cauda pattern. The conus cauda pattern means that there are features of conus pattern plus LMN paraplegia and sensory involvement of the lower limb. So you can call it as conus plus syndrome. And if you see such a pattern, don't think that it is cauda equina lesion. A lesion of the cauda equina and the conus, as shown in this picture, can produce classically the conus cauda pattern of lesion classically seen with the L1 fracture or lesion at the level of the L1 vertebra. Remember that the same pattern can occur. The same pattern can occur with a spinal cord lesion. Need not go for any roots. A spinal cord lesion affects the lumbar and sacral and coccygeal segment, can produce the same picture. And lastly, a pure coda equina lesion. A pure coda equina lesion without affecting the lower down can produce lesion. So this pattern can occur with any of these three lesions. Now what is called a epiconus pattern. Epiconus L4, L5, S1 and S2. Here there will be an emblem and paraplegia, sensory in the lower limb, sparing of conus. Conus will be spared, and UMN bladder. You can call it as conus coda minor syndrome because there is no symptoms of conus. This is what is called, I call epiconus pattern. And remember that the epiconus is usually in the spinal cord. The same pattern can be produced by a laterally placed coda equina syndrome also, as shown in this picture. So it is not specific for epiconus pattern, is not specific for epiconus. A lower down lesion bilaterally, as usually seen in a disc disease, can produce the problem. Now comes what is called lower epiconus pattern. Means L5, S1, S2 is affected, bilateral foot drop, bilateral flexor weakness and absent ankle jerk. When a patient is coming with this picture, your differential diagnosis is usually a neuropathy, a Guillain-Barré syndrome. If it is acute, it is a Guillain-Barré syndrome because everything is foot drop, flexor weakness, plantar reflex absent. You think that it is something in the peripheral nerve. See, it is the epiconus. Remember that the same pattern can occur again with coda equina lesion, which involve the concerned this one. Then comes the upper epiconus pattern, which we usually won't identify. Means L3, L4, L2, L3, L4. Here the characteristics features are LMN quadriparesis, LMN quadriceps. Because of the L2, L3, L4 lesion, you will see the calf is UMN. Calf is UMN, so there won't be any wasting of the calf. The angle jerk may be exaggerated and the plantar may be upgoing. This is the localizing one. When you see this one, this lesion is in the spinal cord. Nowhere else such a lesion can be produced. The site specific upper epiconus lesion. Now, this radicular pattern, what I call radicular pattern, you see that is unilateral. A few radical, one radical or two radical is being affected. There may be a foot drop, there may be a plantar flexor weakness, or there may be a radicular pain and all. And this is what is called LMN, motor sensory syndrome of one lower limb, is called radicular pattern. Don't think that radicular pattern is always radicular. Sometimes what happens is a laterally placed lesion, the spinal cord can also produce unilateral affecting few radicals. So these are the pattern under which you have to classify the lower end of spinal cord, and depending on the pattern you decide that these are the possible site and further work up for that. Now come to the localization of the upper and middle spinal cord, that is dorsal and cervical. As you know that they produce what is called UMN paraplegia. And remember that when it is a UMN paraplegia, there is an entity called spinal shock, which is a complete cessation of all voluntary and reflex movement after acute spinal cord lesion, which may mimic a LMN paraplegia. You may think that the lesion is in the lower spinal cord. Be careful the entity of spinal shock. Then in this segment of the spinal cord there are something what is called cord specific clinical phenomenon, which you should always inquire whether there is cord specific clinical phenomenon. One is what is called a flexor spasm. Involuntary flexor movements of lower limbs spontaneously or in response to minor stimuli is called a flexor spasm. Flexor spasm has got certain important implications. One is it always indicates that UMN lesion of the spinal cord. it always, it indicates that unlikely to be a degenerated. If there is a flexor spasm, it is very, very, very unlikely to be a flexor spasm. And it indicates that it is a more severe disease. These are the implications. So, a lot of information is obtained if you have flexor spasm. I should be a bit careful, unlikely to be a degenerated disease I told, but sometimes a few months back there was a case with flexor spasm in a patient with a motor neuron disease. So, once in a while you may see flexor spasm in other disease, but very, very unlikely. The other phenomenon is, so this is a mechanism of flexor spasm. All the extrapyramidal tract, dorsal reticulospinal tract, ventral reticulospinal tract, and the vestibulospinal tract, all the descending major stimulatory and inhibitory tracts are being cut. That is why it occurs with a more severe spinal cord lesion rather than a lesser extensive lesion. Now, the second cord specific symptom is what is called Lermity symptom, very specific. This is an electric shock like sensation down the spine, sometimes to the limbs and sometimes only to the limbs. It is called Lermity symptom. This symptom is so specific that it indicates a cervical or very rarely a upper dorsal spinal cord involvement, and the structure involved is dorsal column, and it is very unlikely be due to a degenerative spinal disease, unlikely to be due to a degenerative spinal cord disease. These are the implications. And of course, you have to differentiate it from a radicular pain when asymmetric. Sometimes you may see that only the radiation is only to lower limb, you may think that it is a radicular pain. See that the radicular pain is unilateral. The other one is what is called a band-like sensation, band-like. You feel there is something tight in the chest, around the chest. It is again considered to be a posterior collar symptom. Of course, there are controversies. Sometimes you may see that band-like sensation in the leg. This is one of my patients' MRI. You can see that there is a hyperintensity in the lower end of the spinal cord, and she was complaining of a band in the leg. So, band need not be very specific for cervical or dorsal. It can be lower down, and it need not be around the chest. It can sometimes in the leg also. Now, the propriospinal system probably contribute to the truncal tightness. The mechanism is considered to be the abnormality of the propriospinal system rather than the posterior column. Now, cervicodorsal cord clinical approach is very easy. You know that the analysis is, one, you decide the level of the lesion, second, you decide the clinical pattern, third, you decide whether it is a compressive or non-compressive, and finally you decide whether it is intramedullary or extramedullary. But that's all. So, every case should be analyzed on all those 4 dimensions and see whether it is, what is the extent. Now, the first part, level of lesion. You know that for lower end of spinal cord, below the cervical level, you have the Beaver sign, abdominal reflex, and UMN signs in the lower limb. In the lower spinal cord, you will have LMN signs in the hand and forearm, UMN signs in the lower limb, and in the mid cervical level, you will have LMN signs in the upper or forearm. Deep tendon reflex, biceps, supinator, triceps will help, inversion of supinator jerk will help, inversion of triceps jerk will help. And finally, the upper cervical, that is from C1, C2, C3 and probably C4, there are no obvious clinical sign which we call it as blind zone, and above the blind zone you will have what is called a jaw jerk. So, these are the way by which you have to go for a localization, vertical localization of a lesion in the upper cervical segment. You see that I said that the upper cervical spine is a blind zone. But blind people are sometimes more visual abilities than normal people, isn't it? They are more visually able. Like that, you can see that this much signs in the blind zone. From the jaw jerk up, then comes the cruciate hemiplegia, downbeat nystagmus, U phenomenon, reverse dissociative sensory loss, fifth one sensory involvement, neck tongue sign, lingual pseudoathetosis, myelopathy, and scapulohumeral reflex, trapezius reflex, glove and stroking sensory. If you carefully see all this one, there are some of the features which will indicate the localization. One thing which I have to say is jaw jerk. I will say that if I am in a suspected pyramidal lesion, pyramidal signs in the limb, what do you want? The only sign, if you are allowed to do only one side, I will select jaw jerk, because it is a big divide between brain and spinal cord. Brain and spinal cord. If jaw jerk is exaggerated, the sign is above cord. If it is not exaggerated, most likely in the cord. But you have to elicit it correctly. Mouth adequately open. Adequately open means it should not be too closed or it should not be widely open. Several times you may have to adjust the distance of the mouth to see what is the adequate opening. The second one, index finger over the jaw and strike in a downward direction. Downward direction. It should be, can be tested in the lying down position or in the sitting position. Comfortable is in the lying down position. And normal, slight jaw contraction or absent. Exaggerated means bilateral corticoalveolar lesion above fifth nerve nucleus. Remember that when you elicit the jaw jerk, sometimes the contraction of the orbicularis oris may be mistaken for an exaggerated jaw jerk, as we have seen in the previous case which we discussed. It is actually a contraction of orbicularis oris rather than the muscles of mastication or jaw jerk. That is one precaution which you should be careful. Now, cruciate hemiplegia, we are not identifying it because we are not much aware. This cruciate hemiplegia is because of a peculiar crossing of the pyramidal tract. The pyramidal tract, the upper limb fiber cross first and the lower limb fiber cross second. So the crossed upper limb fiber and the uncrossed lower limb fiber is there in the lower lateral medulla together. The lower lateral medulla means that it is at the CV junction. Now, two syndromes are there. One is cruciate paralysis, midline lesion produce bilateral UM and upper limb weakness, which is called cruciate paralysis. There is cruciate hemiplegia, lateral lesion, ipsilateral upper limb and contralateral lower limb produce what is called a cruciate hemiplegia. The next sign is what is called a Ellsberg phenomenon for high cervical cord. Don't remember that upper cervical spine produce only Ellsberg U phenomenon. Reverse are there, atypical things are there, but it is the most popular one. Ipsilateral upper limb, then the ipsilateral lower limb, then the contralateral lower limb and contralateral upper limb. This is explainable by the, not only by the mechanical factor, the explanation is a bit vascular also, but a clear explanation is still not given in any literature because pathological specimens and examinations are rare. Now, what is called a reversed dissociative sensory loss. You all know what is dissociative sensory loss, isn't it? From a few segments in the upper limb or trunk or face, you will see pain and temperature is lost, but touch and other large fiber system is intact. It's reversed, that you will see that the large fiber system, vibration, position sense, etc. are lost from the upper limb, with the preservation of the pain and temperature. It indicates a high medullary, high cervical cord medullary junction lesion due to the involvement of the probably the crossing fiber and its lamination. Now, you all sure that what is V1 sensory loss is the reverse pattern, what is called a divisional pattern, where the V3 element, the V3 is represented up and the V1 is represented down, the spinal cord. This is in the lower upper medulla. This is what is called a divisional pattern. Equally important or more significant clinically is what is called a segmental pattern. Segmental pattern means that the periphery of face, this is the periphery of the face is supplied by the C2, V1, V2, V3 in that onion peel. This pattern is what is called onion peel pattern of trigeminal segmental arrangement. Clinically, this is what is seen, and experimentally you will see divisional pattern. When you do it experimentally, it is a divisional pattern. Clinically, this one. No wonder why the divisional pattern. You see that the segments of the body are arranged like this. This is the C2. Immediately anterior to C2 is the V1 because this is posterior, and the V2, V3 is the most anterior one. That is why it is arranged like that. And in a patient with high cervical cord lesion, this is the pattern of sensory loss. You will see that from the forehead, periphery of the neck, periphery of the face, you will see the sensory loss, but the central part is relatively spared. So, this may sometimes mimic that the periphery is affected. You may see that the maxillary and coaxillary and the mandibular division is being affected rather than the ophthalmic. This is because it is a periphery. These two areas are periphery, and when you see that these areas are affected, you selectively see the perioral area for the involvement. Now, there is what is called a neck tongue syndrome, pain in the neck and altered sensation in the ipsilateral half of the tongue aggravated by neck movement is called neck tongue sung. Sometimes the tongue may be moving inside the tongue like an athetosis. Patient may complain of dysarthria. These are all because of the proprioceptive loss and the sensory loss from the tongue. You can see that the hypoglossal nerve, the proprioception of the hypoglossal or tongue is going through the ansa cervicalis, which joins with the C2, C1. That is why when there is a movement of the neck, there is a numbness and other problems with the tongue. Now, the finger escape sign, you see that the patient is asked to present the arm with the finger forward and palms down. You will see that the little finger is getting abducted. This is called the finger escape sign. And you will see what is called glove and stroking sensory loss. The in testicles, glove and stroking loss is synonymous with neuropathy, isn't it? I will say that it is not glove and stroking, it is stroking and glove. Lower limb first followed by upper limb. Here, whenever you see that a patient is having sensory involvement in the upper limb followed by sensory involvement of the lower limb, it could be a cervical myelopathy rather than a neuropathy, and usually it is high cervical myelopathy. This is what I call glove and stroking, well described in literature. So, you elicit the sign and decide what is the vertical extent of the lesion, vertical extent by this one. Then once you decide the vertical steps, the vertical one, go to the second step, what is called clinical pattern or the horizontal extent. Now we have seen how to decide the vertical extent of the one. Now you decide the horizontal extent, otherwise called the pattern of involvement. The patterns are a complete cord syndrome. Complete cord syndrome does not indicate the severity. It indicates the extent of tracts involved. Whether all the tracts are involved bilaterally, it is called a complete cord syndrome. It need not be severe. Then comes Brown-Sequard syndrome. I need not explain to this group. It's a hemichord syndrome. You can see the tracts are affected with weakness and posterior column sensation from one side, and corticospinal, spinothalamic syndrome from the other limb, hemichord syndrome. The next syndrome is what is called anterior cord syndrome. Anterior cord syndrome need not be due to anterior cerebral artery occlusion. That is the rarest one to produce anterior cord syndrome. Usually it is due to demyelination, trauma and other things. The important feature is you can see that the posterior columns are being spared with the lower limb being affected with weakness. The next comes what is called posterior cord syndrome. Posterior cord syndrome, you know that you think that it is due to posterior cerebral, posterior spinal artery occlusion. It again need not be a vascular syndrome. It is comparatively a very rare syndrome, vascular syndrome. Again it is due to a demyelination or other tractopathies which affects the posterior column. The importance is the affected one is the posterior column sensation. When a posterior column sensation alone is affected, it comes under what is called a posterior cord syndrome. Now, there is a small central cord syndrome. Small central cord syndrome. The characteristic feature of a small central cord syndrome is the involvement of the crossed substantia genovecinosa. The first synapse happens. The second order neuron cross the anterior commissure of the spinal cord to ascend up as the spinothalamic tract up. Remember that this small fiber system need not be pain and temperature alone. Touch fibers are, I already told that touch fibers can be C fiber. It could be proprioception, proprioceptive C fibers. In a teaching there is a disparity, isn't it? When you teach Charcot joint, you will say that it is due to proprioceptive loss. Proprioceptive loss. But you all say that it is due to the pain loss. Pain is lost, that is Charcot joint, and the system affected is proprioceptive. So this is a disparity. You know why the disparity? In proprioception also there are C fiber system, small fiber. They are the one which prevent the nociceptive aspect of the joint movement. When it is being lost, they develop Charcot joint. In syringomelia, you might have seen they coming with the Charcot joint in the upper limb. And when you teach the student that it is proprioceptive loss, they will ask why the proprioception. Proprioception is a pain temperature which is being lost, isn't it? You have to remember that it is the C proprioceptive. Same way, this is the same path which carries the pain temperature as well as itch. Sometimes patients with a syringomelia next time comes to you with the itching of the face or itching of the arms. So remember that this system carries multiple small fiber system including itch, pain, temperature, C fiber, touch, that